I will teach you what is called Part C. Part B is your clinical component. You have Station 1 and Station 2. I will go through this. I have posted that PDF format of what is the exam structure and also how many marks you need to score to pass the exam. Then also I have given you the action plan, what we need to do in order to secure definite pass mark in Part B and Part C. You can ask your seniors just to see whether like with the Lalindra, what he's telling is truth or not. You can ask your seniors and ask how they have been victories in the exam, how it has been just another class for them when they went for the exam. And they, in fact, their examiners, they've asked which university you studied. Unfortunately, it's Lalindra's medical school. Anyway, and the other thing is, I will teach you what is the action plan, how to get a long case, how to get a short case, and the number of classes and how we are going to organize it, the schedule, and also like what they expect in a long case, what they expect in a short case, I am going to teach you. Then also I am going to teach you what they are going to ask in Erpm Part C, that is emergency VIVA. Because before you face the exam, you need to know, and also before you start this course, you need to understand what we are doing here, what you are getting for your money, whether what we are giving you is valuable. That you have to first of all understand. Because you are adults, you have that freedom of making that decision whether you will get the valuable stuff. So you can go through this thing, and also you can ask your seniors, you can ask their pass rate, and then you can understand what is right, what is wrong. Okay. Then also, guys, this time we made a huge change because that is because we have to do entire Zoom classes, because we are not able to do the live classes because of government restrictions. Earlier when we did classes in SIPNA, like we did live demonstration of patients. For each system I have done live demonstration of patients, but unfortunately we can't do the live demonstrations because of government restrictions of student gathering. If they lift, we will again do it, but until such time we will have to do through Zoom online classes. So but I would tell, like, I swear this is even better than the live class. You know why? When we do a live demonstration, so many students, they have to be on top of one, the other one said, the students, they have to, do like this, do like that. They have to peep through other students. But guys, now it's not going to be like that. Why? I am doing video assisted teaching. That is, I'll be doing patient present, like every physical sign I will teach you by using true patients, true exam cases. Because today itself, this evening, I had done 4 videos, actually 5 videos, like 4 systems I covered, the CVS, RS, abdominal nervous system, 4 systems I covered with a cameraman. So we have made, so it's sent for video editing. I won't be able to show that for tonight. I hope I can get the long case how I did it, and I should be able to play that and show you how we are going to do it. So even the long case history taking, because some of the students, they don't know how to take a long case. They don't know what components they ask in the exam. Guys, remember your Erpm Part B Station 1, what you call medical consultation, is different to final MBBS long case. Now this is very important, guys, this introduction part, what I'm saying. Please get it into your head very clearly. Now, this is 100% different to final MBBS long case, the exam structure. Why? In the final MBBS, you are given 40 minutes. In that 40 minutes, you can spend the entire 40 minutes with the patient, and you have to take a very in detail long case history, and also you have to examine the patient fully, and you have to make your summary, differential diagnosis, and you have to present to the examiner. So I'm an examiner, final MBBS examiner. So like, they present to us, then we ask questions and we give a pass, like we give marks to the candidate. So there are always 2 examiners. So don't ever think that exam is biased. Never biased, because 2 examiners, they mark independently. And at the end only, we share our marks and we decide on passing or failing the candidate or giving a distinction merit pass. So now what I want to say is, like, I mean, so in this component, this time in the teaching skill, like, because it's different to the final MBBS, because final MBBS is 40-minute ball game, but your long case, station 1, the medical consultation, is a 10-minute ball game. That means you need to get the history from the patient in 10 minutes. So, like, the patient will be seated, will be lying on the bed, or maybe seated on the bed, and you will be standing on the right side of the patient. Remember, these are golden rules from the very first day I'm telling. So we are, from day one, from this lecture itself, we are in the exam mood, guys, right? We don't have that much of hanky-panky, straight away we are in the exam mood. So always, bedside manners, you get a mark. So always right side of the patient is a compulsory rule. You gel your hands and wipe your hands and make your hands clean. That's number 1. So hand hygiene. So first hand hygiene, and approach with the alcohol gel, and then approach from the right side of the patient, and then you have to introduce yourself to the patient. I am so and so, I am going to examine you. So you are usually, you will be given a chair also, but most of the time students won't sit on the chair. There'll be a small desk by the side of the patient, or the cupboard. You keep your documents, like they give sort of sheets. You keep those sheets on that table and you jot down. Sometimes we place a small card and we say, this is Mr. Herat, 59-year-old patient. Talk to him and get the relevant history. Like that, we paste a small piece of cardboard by the side of the patient, and you are expected to do that. So, so you ask questions. So if the patient is like this, and you are just behind the patient, and the 2 examiners are even behind you, so they are not disturbing you. The 2 examiners are standing behind you, so you can ask anything from the patient. But we as examiners, we are listening to what you are asking from the patient, and then we have a marking scheme, and we put tick boxes for all the questions that you have asked. I will give you the marking scheme in due course, long case marking scheme and also short case marking scheme. I have all, then we get examined, right? The true exam marking schemes. So now, so that is the format of the long station 1 or medical consultation. So you spend 10 minutes with the patient, but you can't spend the entire 10 minutes with the patient. In about 7 minutes or 7.5 minutes, you have to finish taking all the questions from the patient, and the next 1 to 2 minutes, you have to organize your thought process. You must jot down the summary. You have to make the differential diagnosis. Excuse me. Right. So, okay. So, during these 10 minutes, first 7.5 to 8 minutes, you spend with the patient, ask relevant questions from the patient, and the last 2 minutes, you organize your thought process. You have to make a short summary. I will teach you guys each and every long case, every single long case that you can get in the exam. We cover in the exam, and if you get a long case that I have not discussed in my class, I'm going to stand on my head, or I'm going to refund that money to you. Okay, so that much of guarantee I'm giving you. And the other thing is, for every long case, we give you the summary, so you don't have to bother at all about the exam, right? That assurance is given. So summary, every long case summary I'll be giving you. And also not only that, the discussion part, what examiners ask in the exam, will be doing that. So how I'm going to teach that? I'm using the video presentations. Like, say, for example, today I did a case of anemia. So that part is getting uploaded now after the editing. So we just did it today. So very hot top that we need for our abdominal long cases. But I'll just show, like, very briefly how we did that. So I'll give you, like, after I do this discussion, I'll give you about 5 minutes break, and during that time I can get that video and I'll show you what we are doing, how we are doing the long cases, how we are doing the short cases. So all the long cases, guys, I'll be standing, like being an examiner, I'll be standing with the patient and I'll be taking the history. So you exactly know what to ask in the exam. So, most of the patients, like 95% of the patients that you are going to get in the exam will be single speaking patients. So you will have to ask them history in Sinhalese language. But also remember, you also get exam stations in Jaffna and also in Batiklo. So Jaffna and Batiklo, you might get Tamil speaking patients. So, we will also help with some Tamil words and Tamil histories. So I will get a translation, and I will also upload some Tamil translations. So that will help all three languages of students speaking all three languages. So so that is the medical consultation part. So through patient long cases, through exam cases, we are discussing with the patient, and I'm showing you how to go through the long case. Guys, this we did not do in the previous live classes. Why? Live classes we just teach. Okay, you have to ask this in the history, this part you have to ask in this part you have to. But it was not very practical. Now here we are showing the video of a real practical session. It is just like you are in the exam hall. This is what we are going to do. Wait and see. That's what is going to happen, right? So that is your long case. So it's just like you are doing a hospital visit and taking the long case. Like I'm taking the long case, and you are, just listening to that. You will listen that. So that's the best way of learning. So audio, visual, and you are learning through that. Then also, guys, station 2, part B, station 2. That is a short case. You get 2 short cases in the exam. Each short case they are giving 10 minutes. So for 2 short cases, 20 minutes. Now they say for one particular case, you need to score only 45 to pass. But guys, it's so difficult. Why? You should get 45. You have to get 55 for the next case and compulsory, because total pass mark should be 50. So don't think of, now theory you can pass with 45, but not clinical component. So that's why clinical, you have to be more organized, but don't worry, we make you pass 100% assurance given. Not just pass, I get you to the merit pass for you to get a merit position. Right? So because being an examiner, we exactly know what they ask, what you need to tell in the exam, like in your theory case. So now 2 stations, like station 2, the short cases. So we'll be doing system examination. So you have only 4 systems to be thorough with. That is cardiovascular system, respiratory system, abdominal system, and the nervous system. But though we say 4 systems, it's quite lengthy. So many short cases. CVS, they are asking about 8 or 9 short cases, common short cases. Respiratory system, again, about 8 short cases are there. GI and abdomen, like abdomen, there's hematology, renal, and gastro and liver. So there's quite a lot, and oncology. So there's quite a lot in abdomen. So there's about, again, about 10 short cases in abdomen. And also the nervous system, that's divided into upper limb short cases, lower limb short cases, cranial nervous system, upper cranial nerves, lower cranial nerves, and the cerebellar system. So there are 4 components of the nervous system. So each has their own short cases. And I'll be teaching and demonstrating all these short. In fact, one short case already I have done for you all, lower cranial nerve examination today. That I'll be posting when we are doing those short cases. So these short cases, how we are going to teach, same manner, same way. I'll be showing you guys. Now the thing is, when we do live classes, we bring patients, but we can't get all the possible short cases. But me being working in the ward will be showing you, because every day I see these cases, and I will be getting the help of cameramen, the video editing people, and then we will be making videos. And it's just like you are doing a full like museum of short cases and long cases wardrobe. So here in this class, so you will be seeing all these short cases with all the physical signs, right? So that's the format. That is how we are going to teach these sessions. Okay, right? So having discussed that, so that is about your ERPM Part B, clinical training. What about ERPM Part C, emergency VIVA? Now emergency VIVA, guys, there's the medical tract and the surgical tract. So you will be getting medicine VIVA cases, emergency VIVA cases, or pediatric VIVA cases. You never know with so medicine and peds. So in medicine emergency VIVA cases, we know the common VIVA questions that they ask, because I have been emergency VIVA examined several times. So there are common case scenarios that we give. We never ask from this candidate, okay, tell me the management of ischemic heart disease, tell me the management of myocardial infarction, tell me the management of stroke, tell me the management of anaphylaxis. We never tell like that, right? Not good quality examiners. We never give like that. We give a case scenario. We tell, say, for example, anaphylaxis, if you want to ask, what we tell is, a 15-year-old boy got a sore throat, and the clinician has given, or the GP has given amoxicillin to this child, and the child presented with, restlessness, high fever, itching, and now the child is finding difficult to breathe, and his blood pressure was 90/60. How do you manage that patient? So the candidate is supposed to listen to that story very carefully, and he has to figure out this is anaphylaxis, and then you have to tell, sir, this is a case of anaphylaxis, and these are the management steps in anaphylaxis. This is how I am going to manage that patient. So that's how we are, formulating your Erpm Part C VIVA questions. They will never ask, tell me ABC steps of management of anaphylaxis. They will never ask like that. Only very, very sort of very traditional, old-fashioned examiners, if there's one or two, will ask like that. But still, even they have changed. Correct. So that's, guys, the exam format, right? That's the exam format. But in the new course, I'll be telling more things about the exam tricks and exam tips. What the examiner wants. They are my colleagues. I mean, the examiners that you are going to face this exam, that you are going to, face, who will be testing you. They are my colleagues. I mean, they may be a little senior to me, but I mean, I sit with them for the final MBBS exam as examiner, as an examiner, as the co-examiner. Okay, so therefore we exactly know what they ask in the exam. All right. Okay, so having said that, let's see what the component of the exam is. All right. So I have posted this in your all the WhatsApp groups. We have found I posted these things, information in the Erpm medicine mixed revision group. That was the group where students sat for the exam. But we will make, once you make the payments, we will be making a new VIVA group, and you will be added into that group once you make the payments, right? Okay. So Part B, 2021. Right. So I hope you can see, this is, sorry, I have copied this from, the SLMC guidelines. You also may be having this booklet. So you can see the medical track. So you have medical track and the surgical track in Part B. So medical track and surgical track. Okay, so medical track and surgical track. So medical track comprise of medicine cases and the pediatric cases. So the medicine cases are station 1 and station 2. Actually, though they have put these arrows like this, it really doesn't happen this way, because I know the two exam scenarios. So what we do is, one day we have the medical track, maybe in the afternoon we have the pediatric track. You don't do the medicine case and immediately after that you don't go to the pediatric case. It never ever happens like that in any of the teaching hospitals that we have been examiners. Usually it doesn't happen, maybe very occasionally. So though they have put these arrows like this, you never finish the medicine case and then go to the pediatric case and then pediatric case to medicine case. It doesn't happen like that usually, right? They will just have medical cases in one time slot and pediatric cases in another time slot, and a surgical tract on a completely different day, right? So as you can see here, station 1 is called medical consultation, or what you call, I would call it semi-long case. Why did I say semi-long case? Because a true long case is history taking and examination. like how our local medical students, final MBBS students and KDU students, that's how they do. But your medical consultation is like one of the stations like in MRCP or PLAB exam. Why? It's a medical consultation. You have a short, what you call short medical consultation. You are given 10 minutes for this process. Right? So 10 minutes you are doing the medical consultation with the patient. So you are getting a history, and in the next 10 minutes, so that's how these 20 minutes are allocated. The next 20 minutes you have the discussion part with the examiner. I will tell you exactly what discussion format is in the new course. So like how to present the summary, how to present the problem list. Then they ask another question saying, if this patient was given for you to examine, what physical signs would you expect in this patient? That's a new format since 2016. They inserted that part. They introduced that part, which is coming up in the new format of Erpm VIVA exam. If you are given this patient to examine, what physical signs would you expect in him? Make a හැම ළමයාම ඇනගන්නවා. කවුරුවත් කියන්නේ නැහැ. So we train that. We train in our class because I know this. They ask this particular question. Most of the other people, they don't know this. So therefore, most of the time they get very low marks in this component of discussion. What is that? Yes, if this case was given for you to examine, what physical signs would you expect? You need to have some bit of common sense and brain to work out that question. But don't worry, we give those questions what they ask. We will be teaching them. So, and also then finally they ask the investigation plan and the management plan of the patient. So if you go up to the investigation and management plan of the patient during discussion, that means you have secured a victory in that case. Don't worry, you are in the winning seat. You are in the winning seat. You are in the driving seat. Right. Okay. So that is medical consultation, or what I call a semi-long case, because it has only history taking but no examination component. Right. Right. So once you finish that long case, actually in Peradeniya, what we used to do in Peradeniya medical, like Peradeniya Teaching Hospital, and also in NHSL Colombo, what we used to do was like we did not give 5-minute break. Immediately after the station 1, you move to station 2. So, and even other hospitals like Ragama, Colombo, that's how it's happening. I really don't know what's happening in Jaffna and Batticlow, but must be the same process. They also our colleagues. So what happened is after station 1, you immediately move to station 2. So we have cubicles in our teaching hospitals. So in one cubicle we have these long cases, like so. Like in one row we have 3 long cases. On the other, so one cubicle we have 3 beds this side, 3 beds this side. So one cubicle we have about 6 long cases. So we allocate students. And then next cubicle we have another 3 long cases like that. So once you finish the long case, you immediately move to the cubicle with short cases. So you quickly move. There may be just 1 minute, it's not a break actually, 1 minute transition time for you to move from one station to another station. And then the bell rings. So here in our exam setup, we have bell system. We ring a bell. When the bell rings, you have to keep moving. You can't be stagnating in that previous case. Right? So then you move to the station 2. In station 2, I told you 20 minutes, but there are 2 short cases. That is medical system examination. You will be given 2 different systems, either CVS and abdomen, or maybe CVS and nervous system. It won't be 2. It won't be one system. Both cases are not from same system. There are 2 different systems. You really don't know what system you are getting. You may be getting 2 short cases from any of the 4 systems that we examine. Any of the 4 systems that we examine. That is CVS, RS, abdomen, and also nervous system. Right? And then after, so once you do the 10-minute short case, so how does that happen? So these 10 minutes, you will be given about 6 minutes to examine the patient, 6 or 7 minutes to examine the patient. And once you finish examining the patient, you organize your thought process. Take about 30 seconds, half a minute, and organize your thought process. How am I going to present this short case to this examiner? What is the way I'm going to present this case to the examiner? So you have to organize your thoughts. Very important. If you don't organize your thoughts, you're going to be a loser. Why? Guys, this is a very anxious time, very anxious moment, right? So many students panic. Even you may be the brightest student under the sun, but we know even local students, how they panic after we train them so, like they have gone for clinical, ward classes, physical, clinical training for 3 years, but even after 3 years of training an enormous number of ward classes, when they come for the exam, they panic. They panic in front of the exam. Very tense moment, very tense. They're tremulous, right? This true exam experience, I'm telling. Some students, they go mute. They don't talk. Don't do like that. We train you because we do like one-to-one basis discussion. So it's another exam experience to you. So you don't have to worry at all. So now in this station 2, the 2 short cases. So you examine the patients. We being examiners, we don't disturb you. We stand behind you, but we are watching. We also peep through and see, like, is he doing the technique properly? So we are closely watching your examination technique. Guys, remember, because I know the marking scheme, today I will show you the marking scheme of short cases. So in short cases marking scheme, like we give a huge component for your examination technique. Hurry. Now people are so worried about diagnosis. No, my friends, diagnosis is immaterial to us. We are not worried about your diagnosis, right? Now say for example, cardiovascular system, there's a murmur. So you have a classical mitral stenosis murmur. You mess up the case, you don't know that is a mitral stenosis mid-diastolic murmur, you go and say mitral regurgitation. Some other diastolic murmur. But everyone mute themselves. I have muted everyone, but people, those who join later, like, okay. So, like you go and tell a completely wrong diagnosis. Guys, don't worry till you pass. If you have done the examination techniques perfectly, because so for examination, I'll tell you the marking scheme, guys. Examination technique, you give a mark and that we say multiply by 5. Then your interpretation of physical science multiply by 5. Then your differential diagnosis multiply by 1.5. Investigation plan multiply by 1.5. So you can understand diagnosis is not that useful. So you get a big mark, big component from your examination technique that I'll be teaching and training you. How to keep the head in abdominal examination. What components of your hand is being used for the examination of the liver? What components of your fingers are used for the spleen examination? How to do the ballotment? So what is superficial palpation? What is deep palpation? All that we teach. What cardiovascular system examination? What is auscultation? What components you have to see in one particular case? In pleural effusion, how do you have to examine the respiratory system? In the consultation, how you have to examine the respiratory system? All that I'll be teaching by using true patients. That's why I said it's just like you are doing a ward training. Right. So guys, now in the true exam, so you examine the patient in about 7 minutes, 6 or 7 minutes, but that examination technique should be perfect. We are watching you for the examination technique, and that carries the biggest mark. Then interpretation of physical science, how you present. Guys, students start stammering like hell. Some people, I examine this patient, he is well looking, and general examination is not not palo. Not palo that is wrong English, not pale. Or there is no palo, but students like he is not palo. Right? It's wrong English. Right? He is well built, he is not pale, then against stammering. Guys, the time goes. We understand student situations. I know myself, being an examiner, I always try to pass students. I had never failed a single candidate, maybe just 1 or 2 in my whole career as an examiner for the last 5.5 years. Maybe just 1 or 2 students, not more than that. But that's terrible students, right? Even like if I always try to pass candidates because we know how tense the student is, and we try to give clues. Okay, right, relax. If you, so we try to help the student, but some students, when you are so tense and anxious, you can't even get the clues from the examiner. You go blind. These are not jokes, guys. These are true things that we face in the exam. So that's why we are training you. When we train you, it's not difficult at all for you. All right. So, so presentation. Students start stammering and they can't present in the proper order what the examiners want. You have to present the way the examiner wants. You have to present the way my co-examiners, my friends want. Why my co-examiners are here? Because I have stopped going for the Erpm exam, so therefore I'm not an examiner now. I was, but not anymore. So, but I know my co-examiners, my friends, my colleagues, what they ask. So you have to present the way they want, right? The way I want and the way they want. Guys, for that I give you for each and every short case. You ask your seniors if I'm lying. For each and every short case, we give you sample short cases. Say, for example, case of mitral stenosis. So we say, I examine this middle-aged gentleman or middle-aged lady, middle-aged lady's cardiovascular system. On general examination, she was not pale, not cyanose. She did not have peripheral stigmata of infective endocarditis, and there was no ankle edema. When I examined her pulse, it was 70 beats per minute, irregular pulse. Pulse volume was low. The jugular venous pulsation was not elevated, and I did not check the blood pressure. On examination of the precordium, the chest, there was no any obvious chest wall deformities and no surgical scar marks. Apex beat was in the 5th intercostal space mid-clavicular line. I think it is tapping in nature. There were no thrills. Then on auscultation, the first heart sound was loud, and I heard a rumbling mid-diastolic murmur vested in the mitral ear when the patient was turned to left lateral side with the bell of the stethoscope, right? I carefully looked for other murmurs in the other areas of the precordium which I did not hear. But I think the P2 component of the second heart sound is loud. Patient's lung bases were clear, and patient did not have any focal neurological deficits. That's it, guys. See, like a flow of a river. Like a waterfall. That's how I'm training. This is the skill that you are expected to tell. If you present like this, your diagnosis may be 100% wrong. So you will not get a merit pass, but you pass the exam. You pass the exam, guys. Why? You have done the technique perfectly. You have presented beautifully. Right? So I am giving you sample presentations for each and every short case. Each and every short case, I am giving you sample presentations. So all what you got to do is you have to buy hard that and you know, learn the technique of presenting these cases, but apply that to patients. That's why we are doing some hospital visits. Right. And also we are doing discussion through Zoom, like a practical session. So that will help you to improve yourself about presentation skills. So, so the presentation skills, guys, I'm going to give you for each and every short case that they ask in the exam. Not a single case is left behind. Everything is covered. Right. Then, the discussion part. After presenting, then they will ask, that means you have done well. Then they will ask, what is your diagnosis? Then you say, in conclusion, I think my patient has got mitral stenosis because patient got a loud first heart sound, rumbling mid-diastolic murmur, and I think it is complicated by atrial fibrillation and pulmonary hypertension because patient got irregular pulse and also patient got loud P2. So I think it is complicated mitral stenosis with atrial fibrillation and pulmonary hypertension. Like that you should be able to tell. Okay, right, that we will teach you. Then guys, investigate. They ask, what investigations will you do? That means you are a brilliant student, you have done like that. What investigations will you perform in this patient? So you will say, I will do a 2D echocardiogram to see the severity of mitral stenosis, whether there are any thrombus formation, and I want to see whether the patient has gone into heart failure. So I want to do a 2D echo. and I will do a basic ECG. Like if you say that much, that's perfect. And they might ask about management. So you say for atrial fibrillation, I will go for rate control. I will give drugs like digoxin or beta blockers. And also I will anticoagulate the patient with warfarin. If you tell that much, guys, I have given and my co-examiners have given 70 marks out of 100. You can super merit. For a merit you need 60, but you will get a merit pass if you tell that much. So I give sample presentation for that merit. So if you always target merit, you will definitely end up even around that 65, 60 figure. So you are assured of a pass. So 50 is nothing for you. Okay, so that is the guidance, that is the assurance. Alright, then guys, so that is how we are doing the short cases. So once you finish one short case in the true exam, then they bring the bill tongue after 10 minutes, then you move to the next station. Then you have to immediately move to the next station, the next short case. And one more thing, guys. Now, I mean, I can tell these things, but you know, in practice, sometimes it won't happen in that manner. Why? Sometimes one short case may be a little difficult to you. So if you get a difficult short case, maybe you found it a little difficult, you're a bit upset about it, then don't have any hard feelings. That you have to develop as a doctor in your career. If you have hiccups in life, you have to completely forget that and move to the next case. That's the perfect life of a doctor. And we rather than just dragging in that previous past. So your short case, first short case, if it was difficult, forget that. I mean, still you would have passed that case because the thing that I told you. Why? Examination technique and the presentation skills, interpretation of physical science, that carries the biggest number of marks, not your diagnosis. Your diagnosis may be wrong. Don't worry. Don't get upset about it. You go and tell mitral stenosis and the examiner says, so you didn't hear the pansystolic murmur. It's actually a mitral regurgitation. So examiner says, Ayyo mama ivarai setta pochi. So don't think like that. Ayyo mammala. Right? Don't think like that. No, why? You have another short case to do. And you would have done brilliantly in the long case. You have done brilliantly in the long case. So you can compensate for it, guys. Don't think like that. For the examination technique and interpretation of physical science, we have given you a big component. I told you multiplied by 5. Diagnosis only multiplied by 1.5. So diagnosis is not a big deal. Don't worry about what the examiner is telling you. And even if the examiner nods his head, don't get carried away. Some examiners will nod the head even for the failing student. Right? So, like good examiners, because I have been an examiner in the Flinders, like even in Australia, final MBBS exam. So we were given, before the exam, we were given some talks by the dean, how to behave in the exam. So I have been an examiner in Australia. So we were told you have to be like a zombie fellow, right? Neutral. So whether they do well or whether they do bad, that's it. Zombie. Right? So that's the discipline that we maintain. So good examiners will be like that. Don't look at examiners' facial expressions, right? So even if you feel bad about the first case, go with a fresh mind to the second case. The second case may be easy case. Yeah, you can score a lot of marks. But if you go with a very bad, temperament, bad attitude, or like depressed feelings, then even your second case might get difficult to you. So don't let that happen, guys. Don't let that happen. Alright. So that is the victorious pathway in the exam, true exam, in station 1 and station 2. Then about the emergency VIVA. So emergency VIVA, I told you, we give true case scenarios. We give clinical scenarios rather than just asking what is the management of heart failure, what is the management of myocardial function. We really don't ask like that. We give you case scenario, not one. We give about 3 or 4 case scenarios. So what I have been an examiner, so we usually say if you start with MI, then you keep asking about MI, then I move to management of heart failure, because when we know that the student is doing well, we quickly move to another one. And then you jump to diabetic ketoacidosis, then you jump to Guillain-Barré, then anaphylaxis, like that. We run through the whole syllabus, right? I mean, not all the cases, at least 3-4 cases we asked in the exam, in the emergency VIVA. That's what we want to do. Rather than just asking one case, we want to drag this. We want to take the student around most of the emergency case scenarios. So that in the emergency part C, I'll be teaching you. Right. Okay. So going back to our PowerPoint presentation, the PDF. So this is the format. So that I told you in the exam. So the pediatric and surgery also same. So the pass mark you can see here, part B and part C pass marks. These are the pass marks, guys. You can see medical track, the 2 medical stations. So the pass mark is just 45 per station, but that is station 1 you have to score 45, station 1 you have to get 45, and station 2 you have to get 45. But guys, I'm telling you not to do like that. Why? Because the thing is, here look at this end part. Did you see the end part? All of you guys, can you concentrate on this? Did you read this end part? And it has to be, the total score has to be 200 out of 400 for 4 stations. So guys, if you do bad on medicine, you have to do brilliantly well in pediatrics. That usually won't happen. So guys, so don't do that. So just imagine if you just score 45 for one subject and pass, then you have to score 55 for the other component and get this 200 out of 400. That is difficult, getting 55, right? So what you need to do is every component you have to score more than 50 to 55. Every component you have to score more than 50 to 55. This is not like theory, guys. Get this thing really into your head. Here, look at this. So N200, so surgical track also same, because just 45 is not enough. You have to score somewhere around 55. Then even for a difficult case, even if your pediatric case is difficult, you can compensate for it, because medicine and pediatrics both come under the medical track, right? So medicine is the subject where you can score marks, guys. It's a little difficult, but we train you. We give you all the sample percentage. Our students have done brilliantly well, more than 60s they have scored. So medicine is the subject, like guys. You know how I train you for your theory component, part A. What did I tell you always? Do the single best answer questions very well. And you knew that through experience this time, how single best answer questions are valuable. Even MCQ was so easy because we get so many MCQs. But what I'm telling is, medicine is easy to pass. So try to get more marks in medicine. So even if your pediatric cases are difficult, you can compensate for it, because this 200 out of 400, right? So as examiners, we prefer students to maintain 50, more than 50 out of 100. Right. So what is the action plan for a definite pass in Erpm Part BLC Station 1? Station 1 is your semi-long case. Yeah, keep it cool. Why? More than 50% could be obtained. That means the pass mark 50 out of 100 can be obtained without any difficulty. If you go through this top secrets, confidential top secrets. What are the top secrets? Right, the exam secrets. So when you are given the long case, when the patient comes to you, so bedside manners are very important, guys. All of you all wake up if you all are sleepy. This, though tonight's class is at 9 o'clock, we started. Our usual VIVA classes will be from 7:30 to 11:45. 7:30 to 11:45. Usual VIVA classes. So, guys, now bedside manners already I told you, but just I want to reiterate that, reinforce that in your head. What is that? How do you approach the patient in the long case? The examiner will take, okay, come. So the candidate's name. So candidate number 1001, right? So this is Mr. Silva. He's a 58 years old gentleman who has come to our hospital. Talk to him and let us know what's wrong with him. History. Some people might say, okay, talk to him and get the history. You will be, and we tell you, the candidate, you are given 10 minutes, and at the end of 10 minutes, we will ring a bell. And once the bell is rung, you can't ask a single question from the patient. If you do that, you will be failed then and there. Why? That is breaching of exam disciplines, exam rules. You can't do that, guys. So 10 minutes is 10 minutes, bell rings, finish. Right? You thank the patient and come out. So, how to organize these 10 minutes? And what is the first approach? So, when the examiners take you towards the patient, 1011, right? Go to this patient, take the history. So, you go from the right side of the patient, I told you. Alright. So, guys, this is very important. Get this thing straight into your head. So, right side of the patient, always right side of the patient. ලෙඩාගේ දකුණු පැත්තේ යන්නේ වම් පැත්තේ යන්නේ නැහැ කවදාවත්. දකුණු පැත්තේ right side of the patient. And go with a sort of a pleasant face. So your test. Don't go with a staring face, right? The patient will get scared and patient will start panicking, right? So go with a pleasant face. Because when you go with a pleasant face, and remember guys, we don't bring really difficult, the patient, those who don't give a history, we really don't give. Like we bring usual exam patient, we bring the usual exam cases. Like, they have gone for exam several times. So actually some patients, they give the history beautifully. So all what you have to do is just jot down from the patient, whatever they are telling. But we have to train for the, the worst case scenarios as well. So, right side of the patient and go with a pleasant face, and so take the alcohol drop and put some alcohol gel into your hand and do this hand hygiene, and then greet the patient. Good morning, Subha Udayasana, or you can say Vanakkam or something like that. I am finally a medical student. I'm going to talk to you and get some information from you. So that's how you introduce yourself. Mama avasan masare vaidya shishye mama oyagin vistara tikak ganna yawe, right? So me gattata kamak nadda oya kala bila dinne oyanne pahari de pissu katandara. Don't do that, right? So many students ask me, mama avasan masare vaidya shishye tatta mama oyagin vistara tikak gattata kamak nadda. Okay. Kamak tiyena ho nata ho, you have to take. Whether he says yes or no, you have to, because examiners told you to take these, so you go ahead. So you straight away say, I'm finally a medical student, I'm going to ask few questions from you, I'm going to talk to you. Hari tata, mama avasan masir vaidhishi se mangwage podda vistara tika gannawa tata. Whether he likes or not, gannawa, right? That's it. That's nice way of introducing and smile to him. So then, guys, I'll take a blank sheet. Give me a second, guys. I wrote it in the word like for you to show, but the good news is I have received that video, so I will show you that how to do that long case. You are really lucky, right? But before that, Can you please copy this, because I want you to write this for yourself. I have given this in various like in my presentation I have posted, but I like if you can write this for yourself, so that will register in your head. Okay, so station 1. Right. So first you have to get the introduction components from the patient. So what are the components in the introduction? Name, age, occupation. So whether she's a housewife or a farmer or whether she's a teacher or whatever. So amma monawada den karanne rasawa karanawada. So just ask that, and where she's coming from. So residence. Sorry, there's some glare. I hope it's okay. I hope it's not bothering you. So name, age, occupation, residence. This is introduction. So I'll put introduction. Then guys, now comes the most important component. What is that? The presenting complaint. The presenting complaint, PC, you put in short. And guys, now when you go for the exam, now make golden rule. I'm going to tell you a golden rule now, guys. Now when you go for the exam, you will be given a lot of sheets, blank sheets like this. You can't take blank sheets from home. Please don't write anything on your hand, please. Right? Don't put pieces of information in your pocket. Don't do that. Right? So I'll write it for you. So when you get the right. You saw what I was doing. So now I am the candidate. I have gone for the exam. So I am being given some sheets by the examiners. So what I will do? So this is before going to the exam hall. I hope you can see this. It's okay. You can see this. Before you go for the exam hall, guys, you are given these papers. So you can jot down few things, guys. When you are kept in a room, you can write down few things in this paper. So see, introduction. Right? You write introduction. So you just write in your blank sheet these components. Why, guys? When you are tense in the exam, you might forget those essential components in the long case. Guys, there are difficult cases sometimes. Maybe an easy case, but you have messed up that case. But if you go through this checklist, because we have a marking scheme, we always go according to this marking scheme and we give marks for each of these components. So that's why, guys, you have to write this thing before you start seeing the patient. Introduction. Right? So just write down this in your blank sheet. Then PC is presenting complaint. Then HPC, history of presenting complaint. Then, guys, what is this? Very important. So many students forget this. Systemic review. That is systematic review. All the systems you review quickly. Systemic review. Cardiovascular system, respiratory system, abdomen, and GI, and also nervous system. You ask few questions, and the locomotor system. Right? Systemic review. So many students forget to ask this in the exam and they fail. Because guys, we can't give marks because in our marking scheme there's a component, systemic review, whether you have asked. So how can I tick if you have not asked? So I will not be marking and my co-examiner will not be marking. So you won't get a mark for that. Right? So you have to ask that. Even if your diagnosis is correct, if you don't ask that, you won't get a mark. So first page you write down. So first sheet you use only for these. This first sheet is the most important one. And here, right, you are not going to write sentences. You are not going to write in history of present again. Mr. Pereira presented with shortness of breath for 6 months duration. It has got worsened during last 1 week. He also had noticed paroxysmal nocturnal dyspnea and orthopnea. Full stop. Patient also noticed ankle edema for 2 weeks duration. Patient also complains of chest pain. It looks like angina. Patient received special drug in the ward, maybe thrombolytic therapy. Patient is waiting. Then you need about 2 hours for the long case. You need about 2 hours for the long case. Guys, don't ever do that, my dear friends. Don't write sentences. So, history of presenting complaint. So, yeah. So say for example, patient gets there's a case of SOB. So SOB. Technique. Very useful. Shortness of breath. Duration. 1 week. Then so shortness of breath, you have to see whether it's a cardiovascular shortness of breath, like heart failure shortness of breath, or whether it's a respiratory shortness of breath, or whether it's due to anemia or renal disease causing fluid retention. So you have to go through all these systems. So shortness of breath. Sorry, now we are going to do this in cardiovascular system, but I'm just telling you this is a brief overview what we are going to do and how to tackle the long cases. Right? So shortness of breath, you have to ask what you call dyspnea. Then duration you have asked. Then progression, like when the dyspnea started or when the shortness of breath initially started, what type of work you were able to do initially, and now what type of work you can do. I mean, 1 week is too short, we will say it 2 weeks. So the patient might say, so you can ask from the patient, 2 weeks before, how many steps you could climb in stairs, how many steps you could climb in staircase. The patient might say, doctor, like about 1 or 2 months before, I was able to climb about 6, like 1 flight of stairs without any problem. But since last 2 weeks, I could not climb more than 3-4 steps. So only 3-4 steps. Important information, 3-4 steps in a staircase. Then you ask, what about now? Can you walk on the flat ground? Can you climb many steps now? No, doctor, I can't climb many steps. So can you walk on the flat ground? No, doctor, even when I walk about 10 meters, I feel very short of breath. So now, so you can put arrows. Always use flow charts because you can look at this chart and present, guys. This is a very fresh, hot case. No? You know your case. So do the examiner take cover? History? No, I mean, we just, this paper. No, we don't look at this paper. We just dump it in the dustbin. We don't look at your history. Alright. This is for you because you can't remember, otherwise important information you would have forgotten. Right? So then now a patient cannot even walk on flat. So flat, you see like this. So like the shortened forms, flat on flat ground also he can't walk. So I put flat across. Then now when it's shortness of breath or dyspnea, you have to see whether it's cardiovascular or renal. So how will you differentiate that? So for cardiovascular causes of shortness of breath, you will ask, have you also got ankle edema? But that you will get for renal disease also. So ankle edema. Well, kakulat idimila tiyanoda achi? Kakul idipunada? ඔව් මහත්තයා කකුළු තිබිලා තියෙන මගේ. කොච්චර කාලෙද දැන් කකුළු තිබිලා? දොස්තර මහත්තයා කකුළු තිබිලා දැන් සති දෙකක් විතර වෙනවා. So I have got ankle swelling for the last 2 weeks. So try the duration, 2 weeks ankle edema. Then guys, now we don't know with this cardiovascular, we don't know with this renal, we don't know with this respiratory. So now we are going to differentiate. So this, even we are doing the systematic review, right? So we know the common causes of cardiac failure. What are the common causes of cardiac failure? Yeah, angina. So now even the systemic review I'm incorporating here. So this is actually history of presenting complaint and systemic. That's why you need to give 1 full page for this process. What popular angina. Then ask for paroxysmal nocturnal dyspnea, PND. Why? These are more cardiovascular causes of shortness of breath. Paroxysmal nocturnal dyspnea. What a rat and Indian hair no the Husmaganda Beribilla. And they flatted in Nidaganda Pulo, and a Kotagan and then medical and Velad TND. Did you have to increase the number of pillows? Can you sleep comfortably on supine position? Or did you have to increase the number of pillows? Right? Do you feel short of breath during night time? Are you being woken up from your sleep due to shortness of breath? So that is paroxysmal nocturnal dyspnea and orthopnea. Then you ask the renal causes, so angina and all those things for cardiovascular. Then you ask, have you got any reduced urine output? Have you got any puffy face also? What urine yana pramane adu velada? Wage mutra yanakota pena yanawada. So you ask whether you got reduced urine output, periorbital edema. And frothy urine. See guys, this is the beauty, this is the art of taking a really good, effective long case. So you can then look at these things and present, and we are listening to your story, what you are asking from the patient. So renal causes. Then guys, shortness of breath, this is due to respiratory causes. What will you ask? Cough and wheezing. What a cassette in another. Hatiya wage, papu mahansi tiyana, papu ranroom gala sadda henawada. Rat papu in sadda henawada. Achi inhale ka urana machine ka pavichi karanawada. Urana karal, and urana spray ka pavichi karanawada. ඔය ආච්චිගේ හුස්ම ගන්න අමාරුවට. Why? Inhalers we give it respiratory causes of shortness of breath, isn't it? Right? Bronchial asthma, COPD. So that's why you ask for cough and wheezing. See guys, these are not found in any textbooks. These are not found anywhere. Right? This is the super form of teaching. Right. Then guys, the other form of shortness of breath are due to acidosis, but that you can't ask in the history. Then anemia. Anemia also causes shortness of breath. So you ask, pudi wadak karat mahansi gatiya දැනෙනවද? හැමතිස්සෙම ඔළුවේ කැක්කුම කන්න බැරි ගතිය එහෙම තියෙනවද? Why? Symptomatic anemia, shortness of breath with loss of appetite, headache, ආචිට යකඩ පිටි දෙනවද? ලේ දීලා තියෙනවද? ඔයාට ලේ දීලා තියෙනවද? That's another direct question for anemia. So guys, did you know these things before this particular lecture? What to ask in the exam? I'm going to give you a free card if you knew that. This is why guys, this is how we are going to teach in this clinical training, part B and part C, right? So don't worry, you will be assured of a pass, right? So you have to ask, so symptomatic anemia, blood transfusion, ඕවා තමයි එක්සැමින අහගෙන ඉන්නේ. මේක අහයිද? මේක ඇහුවොත් මම දෙනවා marks and I'll be happy. This is the man I want as my intern. That's the impression you have to give to the examiner. So have you had any blood transfusions? Were you given any iron pills? Why? Anemia. So you ask him for anemia story. Okay. Guys, now you have gone through all the systems. Just for the completeness sake, you will ask for GI. For GI, you will ask, gas kahavela tibunada, badaya jirnaya, wamane gatiya kima tibunada. Just for the completeness sake. Then a petta pananati, so that's for GI. Diarrhea, jaundice, vomiting. Then guys, for nervous system, did you have any weakness of one side of the body? Why? Severe heart failure, you can get a thrombus that can travel to the brain and you can end up with a stroke. So, achiki patta pannati wala hema tiyenawada, පැත්ත හිරි වැටිලා තියෙනවද? ඒ මොන ප්‍රශ්නයක් තියෙනවද? නෑ මහත්තයා. Language. So if you really struggle with the language, you have to ask for a translator. Actually, guys, usually Sinhalese students only have problems with the language, because most of the Tamil students they can get the history in Sinhala. Most of Tamil students, and the Muslim students, they are very good in all three languages. So Muslim students, no problem at all. They are very good in Sinhala language and Tamil language both. Tamil students also usually they can manage well in Sinhala language, but Sinhalese students only they struggle in Tamil language. So I'll be giving you Tamil words and Tamil translations too. So I'll help you with that. Right. Okay. So this is what you are going to do, guys. This is how you are not writing sentences. You are making flow charts like this. And by looking at this chart, it's like a nice pendle. So by looking at this, you can present the long case. So learn this art, guys. This is the way you have to adapt. Right. The next chart. So for that component, guys, you have to spend the maximum time, because that, so maybe about total of 5 minutes you spend on that, or 4 minutes on that. So next 3 minutes you have to complete, because if you get a really difficult case, you will be asking that question, this question. You're not getting the diagnosis, you get really upset, and you might forget to ask this. That's why, guys, as you were given the papers, you wrote down all these things. You wrote down all these things, guys. So you are getting marks. Our tick box, we are ticking all these things. When you ask to pass medical history, we are ticking. When you ask to pass surgery, we are ticking. So I have to give you a mark. Even if you fail the case, even if you tell the wrong diagnosis, I have to give certain marks to you. And when you calculate those things, sometimes it comes to the pass mark. So, like, technically I can't fail you, even if you have done really bad on this case. Right? So remember that. So always complete this part also. That's why as you are given the papers, quickly jot down this thing. Right? Past medical history. PM checks. It checks his history. Past medical history. PS it checks. It checks his history. Past surgical history. Then the family history. FH checks. Family history. Then drug history. Allergic history. Don't ever forget the allergic history. Very important. You must answer allergic history. Allergic history. Then drug history. What medications the patient is on? Is he aware of the drugs he is taking? Drug history. Then, guys, the social history and habits. Very important. When the patient is the sole breadwinner of the family, what occupation the patient is doing. So patient has got severe shortness of breath due to heart failure, and patient is a lorry driver. So heavy vehicle driver, truck driver. So he can't drive the vehicle now, right? Heavy vehicles he cannot drive. He feels very short of breath. He's a farmer. He can't do his farming activities. And he is the sole breadwinner of the family. So that is the biggest problem to the patient. And this is a big social problem. And that you have to highlight in the exam. If you are not going to tell that, the examiner will mark very low on you for not telling that. So it's really important. So what patient's occupation is, how the occupation has been affected due to his illness. How the occupation is affected due to his illness. Then ඔයාගේ රස්සාව කරගෙන යන්න පුළුවන්ද මේ වාගේ මේ ඇවිල්ලා තියෙන ප්‍රශ්නෙත් එක්ක? හතියත් එක්ක පපුවේ එක්කමත් එක්ක වාට පුළුවන්ද ඒක කරගෙන යන්න? වාට ජොබ් එක නැති වුණාද? අනේ දොස්තර මහත්තයා මට රස්සාව නැති වුණා. මම මේ අතුදව්කාරයෙක්. I am a manual laborer in a construction field. I lost my job. I have 4 children to feed. And my wife is disabled and I'm helpless. So guys, that's a big social problem. You have to manage that. And if you don't highlight that in your long case, you are going to mark 0 for that part. Right? So social history is very important. Don't ever forget that. Don't ever forget this. Social history. Right? How the disease has affected his occupation. Whether he lost his income. Whether his other family members are affected due to his illness. දොස්තර මහත්තයා මගේ දැන් මේ පැත්තම පන්න නැති වෙලා මට රස්සාව කරගන්න බෑ. මම චූටි බබාලා දෙන්නෙක් ඉන්නවා වයිෆ් pregnant තුන්වෙනි බබා. දැන් එයා මගේ ඔක්කොම වැඩ කරන්නේ එයා. This man has got complete stroke and the wife has to attend and he's pregnant and there are 2 small kids. It's a huge social problem. In pediatrics, of course, that itself is a long case. That this thing itself is breastfeed and all this. So that itself is a long case for pediatrics. So there's a huge social problem that you had to ask. Then you have to ask the habits, that is cigarette smoking. So this may be a patient coming with COPD. COPD, man, you are not going to ask about smoking. Finish. You will have to come the next time also for the exam. Right? A man coming with jaundice, you don't ask about alcohol. You don't ask about intravenous drug use. You will be given very low marks. No excuse. So, but remember, this is the last component. That's why you have to write down this. If you write down this, oh my God. So you always look at your watch. Oh my God. අර ලලිය කිව්වනේ මේ මේක අහන්න කියලා ලලිය කියන දේට අහන්න එපා අදවත් මේක මම එහුවේ නේ ටක් ටක් කළා හරි හරි පාස් මිනිස් කියන්න ආච්චි මම මොනවද ලෙඩ හැදලා තියෙනවා මිනිස්සුලා ආච්චි මොනවද ඔපරේෂන් කරලා තියෙනවා නෑ නේ හරි හරි ආච්චි අමිනාඩි දෙකයි තියෙන්නේ ආච්චි වගේ පෞලි කාටවත් මේ වගේ ලෙඩ හැදලා තියෙනවා ඇස් කහ වෙලා ලේ දීලා තියෙනවා නෑ නේ හරි ආච්චි හරි මොනවද ආච්චි නේ ඇලර්ජිස් තියෙනවද මොනවද බෙහෙතක් ගත්තම විස වෙනවද ටක් ටක් ගාලා guys that 1 minute because I told you this that 1 minute you will remember this and still you won't be failed why you have gone through all these things and the examiner has to mark these tick boxes. You understand? You understand how valuable this is. Right? Fail උන දවසට තමයි ඒක තීරෙන්නේ. Right? ඒ fail වෙන්න එපා. Fail වෙන්න නැති වෙන්න මොකද අපේ fail rate එකක් නෑ. Our all students they pass but go through this. So habits, ask about alcohol. So alcohol you have to ask if you can calculate the unit that will be great, but at least amount of alcohol is using. Whether he is a dependent drinker, whether he is having problems related to alcohol, whether he is having withdrawal symptoms. If he is a smoker, you have to calculate the pack years, the number of pack years. Then intravenous drug use. A case of jaundice, you have to ask about IVDU. A patient coming with fever. Now, very common long case is fever of unknown origin. That is pyrexia of unknown origin. Doctor, මට මේ උණ දැන් මාස දෙකක් තිස්සේ උණ බහින්නේ නෑ doctor. You are not going to ask about intravenous drug use. We'll fail you. Why? Why? This may be a patient who has got right-sided infective endocarditis. So you have to ask intravenous drug use. He may be having hepatitis C, and that may be the reason why he has got this long-standing fever. A case of jaundice. Maybe due to hepatitis C, he would have got HIV infection and that's why he's presenting with long-standing fever. So you have to ask intravenous drug use. Very important. Then guys, the next thing is you need to ask sexual promiscuity. That's the most embarrassing question. But you have to, so you must show your professional colors, professionalism when you ask that question. Achi, සම්බන්ධකම් පවත්වලා තියෙනවා. So you can't ask that from Achi, no? You will be slapped by the Achi if you ask. So maybe in a fairly younger patient, so a patient coming with jaundice or patient coming with continuous fever, then you must be very professional. You have to ask මේ ප්‍රශ්නේ මම අහන්න ඕනේ මොකද මේ ලෙඩක් හොයන නිසා ඒ නිසා ඔයා වැරදි ඔයා not වැරදි I'm sorry දන්නේ නැති කෙනෙක් එක්ක අනියම් අනාරක්ෂිත sorry not අනියම් I'm sorry for that word අනාරක්ෂිත ඇසුරක් පවත්වලා තියෙනවද. So have you had unprotected sexual intercourse with the unknown partner? That's the question you need to ask. Intravenous drug මොනවද ඉන්න injection කටු වලින් මත්ද්‍රව්‍යයන් විදගෙන තියෙනවද. So you can't be asking that from the Achi or Sia. Like you have to be a bit more tactful. But you can ask that from a middle-aged person or a younger patient. Right? So all those things you need to ask. And one more thing you have to ask, are you independent on your ADLs? What is ADL? Activities of daily living. That rheumatoid arthritis is another long case. Rheumatology. Rheumatoid arthritis case, SLE case, epilepsy case, stroke patient. All these are long cases. stroke, rheumatoid arthritis, SLE, epilepsy. In that case, if you are not going to ask, are you independent on your ADL, activities of daily living? One of the activities of daily living can. You're washing, you wash yourself, no? You're grooming, dressing, feeding, and toileting, the basic things in your life. So, washing and cleaning, dressing, grooming yourself, feeding, and toileting. Are you independent on that? A case of rheumatoid arthritis, patient has got arthritis mutilated, fingers are like this. He cannot use his hands to it. He cannot use his fingers to use the cutlery. So someone else has to feed. There, doctor, mage puta, ya rasa minut asuna, mata me kema kanna bonnawat vidiyan naha, mata ඇවිදින්න බැරි නිසා මට ඔක්කොම කරලා දෙන්න මගේ පුතා. So that's a big another social problem. Why? The son has to resign from his job just because this patient is dependent. So very important question. Are you independent on your activities of daily living? So you must ask that from the patient. Executives love that type of candidate. He's the real clever man. He's the man we want. And you must show your colors, show your confidence. We train you, we increase your confidence levels. Right? So those are the components of your long case. So don't ever forget to write down these things so you won't forget this list. Did that stick your head? It's very important. Right. Having said that, I will just write down these things. So presenting complaint. So I told you how to evaluate that. Like the primary problem, how to evaluate that by using a chart. Then you have to ask past medical, the presenting complaint with duration and the progression. So presenting complaint with duration and progression of symptoms. Progression of symptoms. Then ආච්චි කිව්වා නේද මට වාට හති කියලා. දැන් මේ හතිය මාස 8කට ඉස්සෙල්ලානේ පටන් ගත්තේ. ඉස්සෙල්ලා ආච්චිට මීටර කීයක් විතර ඇවිදින්න පුළුවන්? ඉස්සෙල්ලා දුසර මාසේ මට මීටර 500ක් විතර ඇවිදින්න පුළුවන්. දැන් කොච්චරක් ඇවිදින්න? දැන් ડોක්ටර් මීටර 10ක්වත් ඇවිදින්න බෑ. See the progression. Earlier patient was used to walk 500 meters and then only she became short of breath. Now patient can't walk even 10 meters. So the dyspnea has got progress. It has got worse. You must relate that to life events and then show the progression of dyspnea. So duration of symptoms and progression in the chronological order. Then guys, history of presenting complaint and systemic review. History of presenting complaint and systemic review. So that's where you put these charts. Shortness of breath, duration. So you put these various things in order to make a differential diagnosis. That's why you have to give them one full page for this. So important. And you have to go through all the systems. You have to go through cardiovascular system. You have to go through respiratory system. You have to go through the GI. You have to go through the nervous system. So I'll put CNS there. And finally the locomotor. And the renal. Locomotor system is whether you got any arthritis, joint swellings, and also renal system. Endocrine system you have to ideally ask, but you cannot ask that, like in the history. So that's why in the past medical history we ask for diabetes. Right? So in the systematic review, make sure that you cover all these systems. And I am going to teach you what questions to ask. මේක දැක්කම බය හිතනවා අනේ මෙච්චර අහන්නේ කොහොමද මේ මනුස්සයට පිස්සුද මේ ලලියට මේ විනාඩි 2-4යි මේ ඔක්කොම අහන්න පුළුවන් කොහොමද කාඩියෝවැස්කියුලර් සිස්ටම් මොනවද අම්මා දැන් ඔයාට පපුව එකක්ම හැදලා තියෙනවද ඉස්සෙල්ලා කොච්චර කාලෙක තිස්සේ පපුව එකක්ම හැදෙනවද ඒ පපුව මැද නිකන් තද කරලා මිරිකලා වගේ එකක්ම හැදෙන්නේ මට හතිය තියෙනවද ෆ්ලැට් එකට නිදා ගන්න පුළුවන්ද කොට්ට ගාන වැඩි කරන්නේ නැතුව කකුල් හිටිමිලාද that's enough guys. We are not going to ask all the questions in cardiovascular system. This is a ball. Guys, if you are the best actor or best actress on that day, you win the ball game. Right? You win the ball game if you are the best actor or best actress. Right? Just to please the examiner. Right? That's what we are doing. We are just playing to his tune. right? And then you get him to dance to your tune. A good candidate. That's what you need to do, right? Right. Then the mang examinate ready. Right. Mama make a hanga, magi kahangi noya. But lagu then. That's what you should do. So cardiovascular, respiratory system. I cassa over there. Cassa kibati the popo hati avangi or urna karalari urabishini kakaripa chikalati. GI ask what a badeke kumakna mamadikatia, but a burlatianagatia. Have you got any abdominal pain? Have you got any diarrhea or vomiting? Have you got any jaundice? Hepatobiliary system also covered. Have you got any weakness of one side of the body? Have you got any numbness in your body? That's for nervous system. Examiner knows, this bugger knows about the system review. He's asking all the systems. Right? Fit nervous system. Locomotive arching monod handi kakuma handi idimi makti. Right? So locomotive system. What about your urine output? Have you got any reduced urine output? Frothy urine. That's for periorbital swelling. That's for him. Wait a minute. There. 1 minute you can train yourself to ask this. Oh, sorry, not maybe 1 minute. May not be 1 minute, just maybe 2 minutes to ask all that question. So you have to train yourself. Guys, this is something that you will do practice. Practice. Right? In theory classes, what did I say? Do the questions. Right? Practice the questions. So here, practice the long cases, our sample presentations. Practice the short case sample presentation. Okay, right. Good. So that is history of presenting complaint and systematic review. It is very clear to everyone, guys. It is something difficult. If you have got any questions, understood areas, difficult to understand areas, please ask me. Then, guys, you are going through that checklist. Past medical history. What are the essential things you are going to ask? Diabetes, history of diabetes. If the patient says, oh doctor, but diabetes is C-niti. That's how they say, C-niti. C-niti. Then you have to ask, for how long did you get diabetes? Duration. 4 years. Clinic. Are you being followed up in a clinic? So follow up. Don't worry, I'm teaching you all these things in the due course. Follow up. How is your control? What did the doctors say? Did they say that you are adequately controlled? And quickly ask for macrovascular complication. Actually, aspenia dua hematina mother. Then I'm actually mutra penapena vagi. What am I asking? Yes, I'm asking for retinopathy by asking reduced vision. I'm asking for frothy urine. Why is that? Nephropathy. Then I ask, have you got any numbness of your feet? What am I asking? Peripheral neuropathy. There's neuropathy. So microvascular complications covered. Macrovascular. So don't repeat the same questions. You are not supposed to repeat the same questions. Right? So asking for microvascular, macrovascular, so control, then complications. This is what you need to ask. So if you got a case of, say this patient has got jaundice, right? The man coming with jaundice. Or take a case of ischemic heart disease. The patient has got very common long case is ischemic heart disease, angina. We commonly give that in the Excel, angina. So man coming with chest pain and in the past medical history patient says, Dr. diabetes. So you have to go through this. Duration of diabetes. Doctor diabetes doctor follow up then a clinic මොකද දොස්තර මාතෘ කියන්නේ වගේ කන්ට්‍රෝල් එක හොඳයි කියනවාද මේ සාමාන්‍ය CD පාලනය හොඳයිද then complications microvascular macrovascular complications the way I asked that's it then have you got any hypertension so first ask for diabetes then ask for hypertension have you had any ischemic heart diseases have you got any renal disease? මොන වකුගඩුව අමාරු තියෙනවද? පපුවේ අමාරු හැදිලා තියෙනවද? ඇදුම අමාරුව තියෙනවද? So cover the basic things in the past medical history. Very basic things in the past medical history. Okay? Very basic components. Then, just give me a second, please. I'm sorry. Yeah, actually, we are supposed to do these things when we are doing the true lecture, but I'm just giving you a brief overview. So like that, so you ask the past medical, there's past surgical history. Have you undergone any surgeries in the past? Right? Then family history. So like in the case of jaundice, you will ask, are there any other family members with similar illnesses? Angina. Probably තවත් කාටවත් මේ පොපුවේ අමාරු හැදලා තියෙනවද? heart attack අමාරු හැදලා තියෙනවද? The case of diabetes, do you have any other family members suffering from diabetes? Strokes, you ask whether there are any other family members suffering from strokes. Why? There can be familial cases of cardiovascular diseases, isn't it? So you have to ask that. Family history, so important, don't forget. Then guys, the allergic history. Then the allergic history. So you have to ask, do you have any allergies for any drugs or any food items? Then the drug history. So do you remember the common drugs that you are on? ඔයා දැන් නිතර ගන්න බෙහෙත් ඔයාලට මතකද? ඔයා මොකක් හරි බෙහෙතක් දීපු කාලිනව ගන්නවද? මොනවද? ප්‍රෙෂර් වලට බෙහෙත් ගන්නවද? දියවැඩියාවට බෙහෙත්, මේ බෙහෙත් වල නම් දන්නවද? So at least if the patient can say, Doctor, I am taking pills for hypertension, I am taking pills for diabetes, I am taking pills for epilepsy. That's good enough. So he's on medications for epilepsy. He's on medicines for some psychiatric illness. Like that, you better write that drug history part. Okay? Right. But don't wait without asking that. Don't forget that, because we have to tick that box. Then guys, social history. So social history, මොකද දැන් රස්සාව කරන්නේ රස්සාවක් නැති වුණාද මේ ප්‍රශ්නේ නිසා මේ ලෙඩ නිසා? Have you lost your income? Have you lost your job? How many days you were absent to work? How many days you were absent to work because of this illness? Please ask all that. Okay, right, good. And then ask about smoking. How many cigarettes you smoke? Do you smoke? How many cigarettes a day you smoke? Patient says, Doctor, මම අවුරුදු 18 ඉඳන් බිව්වා. දැන් මගේ වයස අවුරුදු 68යි. එතකොට මම අවුරුදු 50ක් බීලා තියෙනවා. දැනුත් බොනවද? නෑ ડોක්ටර් ගිය මාසේ මම නැවැත්තුවා. So he's an ex-smoker. So you have to present like that. He's an ex-smoker, right? But he has been smoking for the last 50 years. So 20 cigarettes a day for 50 years is how many pack years? Huh? 50 pack years. 20 cigarettes a day. 20 cigarettes a day for 1 year is 1 pack year. Okay, so you have to ask that from the patient. Very clear. So then guys, you need to ask, so smoking, then ask about, some patients you might have to ask about beetle chewing. Say a patient coming with difficulty in swallowing, dysphagia. A patient coming with dysphagia, progressive dysphagia. Or patient coming with loss of appetite and loss of weight. You are not going to ask about beetle chewing. You ask, cigarette puno, naha dostar, chick vidra, mago khate vattiyanne. Em kiyana patient la. Shit, mago khate vattiyanne. Dostar mahathe tamay mago khate diyan dostar la ni. Right, okay. Right. Do you drink? Then, but the man is chewing beetle. So you don't ask that. Oh, matakani cigarette ka rakhu vitarai. Right? So, and about sexual promiscuity. But don't forget about beetle chewing. So patient says, he's a beetle chewer. And that's why he has got esophageal carcinoma. Loss of appetite, loss of weight. So don't forget that, beetle chewing. Right? Then ask about alcohol history. So when you take the alcohol history, you have to ask, the quantity that you take for a day on average, and for the number of years, ask the number of years that you are taking alcohol. Are you a regular drinker or are you a social drinker? So හැමදාම දිනපතාම මත්පැන් ගන්න නම් පාටි එකකට ගියාම විතරද ගන්නෙ. Right? Whether you are a social drinker. Then on average, what is the consumption of alcohol, the urines for a week? කොච්චරක් විතර alcohol ගන්නවද දවසකට? නැත්නම් සතියකට කොච්චරක් විතර ගන්නවද? අරකු බිව්ව නැති දවසේ ඇඟිලි වෙවුලනවද? Withdrawal symptoms. Fit එක හැදිලා තියෙනවද? Why? Withdrawal seizures, withdrawal fits. So you have to ask all that in the history. Then in the relevant case, you have to ask about intravenous drug use and travel history. See, a patient with jaundice, මේ හොඳට අහගන්න මේ ළමයි පරිප්පු කාපු තැන්. හරි? Sometimes there have been some nasty examinations, they have failed cases like for not asking some important. Because the thing is, guys, is like this. When an examiner really wants to fail you because not asking some very important component, they can ask the rest of the questions also to fail you. You know, because this is not a theory exam, no? So that's why, because the very important things that you have to ask in the exam, you must ask. So a patient with PUO or FUO, fever of unknown origin, or case of jaundice, or case of loss of appetite, loss of weight, you have to ask about travel history. Why? He traveled abroad, he would have got some hepatitis C or HIV abroad, or he would have got some, some malarial infection in that particular country, or some tropical illness of that particular country. So you have to ask that. Fever of unknown origin, you must ask for travel history. If you don't ask that, the patient has already traveled. So make case examine the patient has traveled to Africa. He has gone to Masai Mara, Nairobi, to see the wildlife trip, safari trip. And he has been bitten by all the mosquitoes. And now he's coming to Sri Lanka and he's coming with fever, continuous fever. And the reason is that we have diagnosed that he has got malaria. And guys, you did not ask that travel history. ඉතින් මේ ඔක්කොම කේස් එක තියෙන්නේ ඇෆ්‍රිකා ගියා ඇෆ්‍රිකාවෙන් මලේරියා හැදුනා. ඊට පස්සේ තමයි fever of unknown origin. And you didn't ask that travel history. Finish. So student might say, how wicked these examiners are. Just one point I didn't ask. I asked all the components, but he failed me. How unfair this exam is. Student might tell like that. But guys, that's not unfair. Because the most important component of the exam, you missed. So that's why I'm telling those components you must jot down and ask. Travel history. Then in the relevant case, ask for sexual promiscuity. Unprotected sexual intercourse with unknown partners. Alright. Then guys, you would have seen the last component. What is this last one? So to complete this stuff, to complete this one and this one, it should not take more than 7 minutes or 7.5 minutes. By 7.5 minutes, you should finish this process. And the last 2 minutes, you must write this one. What is this? Yes, what is it? Summary. Very important. Summary and problem list. Summary and problem list. So just write there. It's not only summary. Summary and problem list. So guys, last 2 minutes, this is the brilliant student. The brilliant student won't utilize the entire 10 minutes talking to the patient, right? Entire 10 minutes you should not waste on patients. You should finish your history in 7.5 minutes. Last 2 minutes you spend for the summary and problem list. And you organize your thought process. How am I going to present this case? What are my differential diagnoses? That is very important. That's the most important half a minute or 1 minute. Right? Organizing your thought process. Because guys, now you are talking to the patient for entire 10 minutes and the melody, tongue. Right? Present you and examiner says, okay, right, come. So when they say come, you can't do that. Tongue when the bell rings, you have to turn thank the patient and come towards the examiner. So 2 examiners are standing and you are in front of the examiner. Sometimes there will be 2 chairs and there will be a chair for you. Yes, last time we kept in Peradini like that. Okay, present your summary. Straight away examiner is saying, present your summary or tell us your problem list. Guys, straight away they are telling, present your problem list, present your summary. You think make a headwind like about a summary only a man who has been teaching for years and years and years, could tell that. But even the best of a student can't do that. If you have been talking just to the patient for 10 minutes and straight away when they ask you to present summary, you can't do that. So you have to organize yourself. That's why you must spend about 2 minutes organizing yourself how to present the summary and problem list. And that I'll be telling in each of my long cases. Okay, right. So that's it. That's it for the long case. Right? The discussion part, I told you what they're asking in the exam. Right? Okay. So I'll give you just a 5-minute break. During that 5 minutes, I'll try to download that video that I did, and let's see. So just take a 5-minute break. Now it's 5 to 11. Sharp at 11, we will meet up. Sharp 11 o'clock, we will meet up. I can see you guys are having your dinner and the snack and all that, but poor Lalindra is still hungry, but I have no time to have my dinner until this class is over. Right. It's okay. Welcome back after the break. And guys, you got the best opportunity to see what we are going to do in the true exam. Look at this video. Just I did at what time? Maybe at around 3 o'clock this evening. So I got on the cameraman and like edited this video, and he has edited for me. So let me play that video. Watch this one very carefully. So welcome to Erpm Medicine Part B and Part C. So in Part B we have Station 1, the long case, and then we have Station 2, the short cases, 2 short cases. So first we are going to discuss on Station 1, the long case. That is where they analyze the history taking skills. How to take a history, that is what they call medical consultation. So in the medical consultation, the format is you are given a patient and you will be sitting with the, you will be seated or you will be standing near the patient, and you are given papers and you are expected to take the history in 10 minutes time. So in 10 minutes, you have to take the full history. But you can't take the entire 10 minutes for history taking, because you have to write down few things and you have to make your summary, and how to present the case you must organize. I will show you what components that you have to take. So you must finish the long case in about 7 or 8 minutes. Then after that, next 2 minutes you must keep how to plan your presentation, how to do the discussion, what are your differential diagnosis, that type of things to plan out. And then, so once your 10 minutes are over, they ring a bell, and then the second component starts. The second component starts with the discussion. So usually, if I am the candidate, so I'll be like this, and behind me there will be 2 examiners. They never face you. They will be behind you, so that they won't disturb you. So the 2 examiners will have a tick box. I will tell you in the due course what components that they analyze or what components they mark in the exam. So they will go through those tick boxes and see whether this candidate has asked during the history taking with the patient whether relevant things have been asked. So at the end of 10 minutes, as I told you before, they ring a bell, and the second 10 minutes are for the discussion. And during that discussion, first we ask the candidate to present the summary. We never get the candidate to present the full history. So it's just a summary. So therefore you have to make a summary. You have to make a summary like this. I'll show you these components. Summary. So you have to make a summary, and also you have to make a problem list. So that at least that component you must prepare and keep, because when they ask, okay, present your summary, you should know what to present. So present the summary, and also present then they will ask what are your problems, or what present your problem list. And then they will ask if this patient was given for you to examine, what physical signs would you see in the patient. Remember, in your Erpm Part B Station 1, you are not supposed to touch the patient, you are not supposed to examine the patient. That is only Station 2. So they ask what physical signs you would see in this patient. So then you should plan out that, and in our classes we'll be teaching how to present that part. Then they ask what are your investigation plan for the patient, and what is your management plan for the patient. And that is the full discussion, which goes on for about 10 minutes. So at the end of 10 minutes, then there are two examiners. One examiner will give an individual marking for that candidate. The second examiner will give another independent marking for that candidate. Then once the bell rings at the end of 20 minutes, that means 10 minutes for the discussion. Then after 20 minutes, the both examiners, they discuss the two marks, we compare, and then we give the final mark, and then only we decide on passing or failing the candidate. Most of the time the students pass, unless you make a big mistake, right? So what I will do is I will teach you in the very introductory lectures how to present a case. So I will show you what components that you need to write down when you are given these blank sheets. When you are given the blank sheets, you need to jot down few things in the blank sheet so that you won't forget. Because sometimes if you get a really bad case, you might forget the components of the exam, because each of these components will be given a mark. And if you forget one component, you are going to lose that mark. So introduction part, you have to write what the name is, age, occupation, and where the patient is coming from, the residence. Those are essential for the introduction of the patient. Then you must ask the patient, what is the main complaint which brought you to the hospital? Those are presenting complaint or presenting complaints. And also the duration. So guys, it's so important. What you need to ask is presenting complaint. How will you ask that? What is the main complaint which brought you to the hospital? Now you know why. Guys, we are dealing with two patients. Patient might say, a doctor may giya masa atakati isilla me garbashya ayin karane garbashya ayin kalla doctor so hariya amaruna ide passe mata evida gannat beri una. So arches are like that, right? Usually they go right around the world and then only finally come to the final point. මේ මගේ වූඩ් එක අයින් කරානේ ගර්භාෂය අයින් කරා ඊට පස්සේ හරි අමාරුයි ડોක්ටර් එකට කන නැහැ ડોක්ටර් කන්නත් බැලුවා හරි අමාරුයි ඊට පස්සේ මොකද උනේ ඇච්චි and then she will tell, but she's coming with shortness of breath due to heart failure. So when the patient starts like that, අද යන්නාච්චි නෝ වඩන්නේ මට මේ දැන් අපෝ එහෙම නෙමෙයි හරි ආච්චි මට ආච්චි දැන් කියන්න මේ දැන් මේ පාරාච්චි දැන් හොස්පිටල් එකට ඇවිල්ලා ඉස්පිරිතාලට ඇවිල්ලා මේ පාර ඉස්පිරිතාලට ආපු ප්‍රධාන අමාරුව මොකද? What is the main complaint which brought you to the hospital this time? You have to ask like that in the long case. You got my point, guys. So what is the main complaint which brought you to the hospital this time? It's very important to ask like that, right? Right. මේ පාර ඉස්පිරිතාලට ආපු ප්‍රධාන අමාරුව මොකද? ප්‍රධාන අමාරුව මොකද? මහත්තයා මේ හතිය මට හුස්ම ගන්න අමාරුයි හති කොච්චර කාලයක්ද duration next immediate question කොච්චර කාලයක් මේක තිබුණා duration right and කොහොමද මේක වැඩි වුණා මේක එන්න වැඩි වුණාද progression. So you listen to that. I'm doing a sample case now. This is the introduction part. After that I'm giving you a sample case. This 30-minute video, but I'll be playing all that. You are not sleeping, you are not feeling sleepy now, guys. Like, this is a very valuable thing, huh? Don't feel sleepy. Even if you are feeling sleepy. This is a very romantic scene, man. See how beautiful that is. Did you have these problems? in a sequential order. Then I have put here HPC, that is history of presenting complaint. HPC is history of presenting complaint. Okay, so that is, we have to put them in a chronological order, how these problems, like say for example, if a diabetic patient came with leg swelling, you have to ask, okay, for how long did you have the leg swelling? Did you have reduced urine output? Did you have any shortness of breath also? Like, or did you have frothy urine? Like that, you need to ask few questions. So like that, you have to go through this part in a chronological order. That is history of presenting complaint. And also during this part, we are also trying to evaluate the etiology. So for example, if a patient coming with ankle swelling, it can be due to heart failure, it can be due to renal failure, it can be due to cirrhosis. So you have to ask few questions for heart failure. You have to ask few questions for renal failure. You have to ask few questions for cirrhosis and see what the underlying condition is. So there will be some positive points, there will be some negative points. Then also there's something called systematic review. Systemic review or systematic review. This is very important. That is, you have to go through all the systems like cardiovascular system, the respiratory system, the GI, the abdominal system, nervous system, like that. And we are definitely giving each component at least a mark. Then after that, you must ask, I have slightly changed the order actually, you better ask the past medical history first. Then you ask what other previous medical problems patient had, past medical history. Right? And their duration. Say for example, if the patient is coming with a chest pain, that is angina, then you need to ask in the past medical history whether the patient is a diabetic. And then you ask for how long you had diabetes, how you have been followed up, what treatment you are taking, what complications, all that. When the patient got hypertension. So in the past medical history, make sure that you cover diabetes. So right here, DM. You must ask for hypertension. So diabetes, hypertension. You ask for dyslipidemia, bronchial asthma, like that, few important medical conditions. When the patient has undergone any surgeries, PSA, checks his past surgical history. When the patient had any surgical problems, surgeries in the past. Then ask for the allergic history. Don't ever forget this. Any food or drug allergies. And then you must ask family history, where the patient had similar medical problems in the family members. Family history. Because certain conditions, say for example, hereditary spherocytosis, those things, family type 2 diabetes, family history will be very important. Then you must ask for drug history. What drugs patient is on? What sort of drugs patient is taking regularly? So drug history. If the patient knows the names of those drugs. And then the social history. So what patient's occupation, whether the patient is the sole breadwinner of the family, how she is living, whether she is alone, whether she is independent on her activities of daily living. And also habits like smoking, alcohol, intravenous drug usage, recreational activities, sexual history, all that comes under this component. So I gave you the components of your long case, station 1. So let's practice this and see. So in each and every case that we are doing, we'll be going through this format over and over again. So it will be just like another exam experience for you. Right. So let's do with this patient. Let's start there. So remember, since I am teaching today for you all, I might take a little more than 10 minutes. So now the time is 2:35. Yeah, so 2:45, or like in the exam you are given up to 2:45, but because I'm teaching, I might take a little longer than that. Okay, so let's start the process. You start from the right side of the patient. You never come on the left side of the patient. Always, these are called bedside manners. So you also, now guys, I'm going to show you a true long case, how to do the long case. This is how we are going to teach, guys. Like, we'll be using lots of sample video presentations like this, video assisted teaching, and also video assisted short case examination, station 2, the difficult part. So that's how we are going to teach you. It will be really beneficial for you. Stand on the right side of the patient, and as you go, before you reach the patient, you should have the alcohol rub, and you should rub your hands with alcohol. And then you must greet the patient. You should not go with a staring face. So you tell the patient, you must introduce yourself and greet the patient. Maybe you say good morning or something like that, or good afternoon, and you say, Achi, Mama, Avasana Vasari Vaidya Shishya. So because you are sitting for the exam, you can say you are Avasana Vasari Vaidya Shishya, or finally a medical student. So I will also go down to finally a medical student, and now you will tell how to present. I am finally a medical student. I am going to have a small chat with you. Mama Avasana Vasari Vaidya Shishya. So I will take about 20-25 minutes because I am teaching while taking this history. Mama Avasana Vasari Vaidya Shishya. Mama ඔයාගේ විස්තර ටිකක් ගන්න යාළුවා. ආච්චිගේ නම මොකද්ද? කමලා. වයස කීයද ආච්චි? 62යි. රස්සාවක් කරනවද? නෑ, ගෙදර ඉන්නේ නේ. So she's a housewife. කොහෙද පදිංචි? උඩුබද්දාව. Right. හොඳයි. දැන් ආච්චි මට කියන්න ඔයා මේ ඉස්පිරිතාලෙට ආපු මේ පාර ඉස්පිරිතාලෙට ඇතුළු වෙච්ච ප්‍රධාන අමාරුව මොකද්ද කියලා චුට්ටක් හයියෙන් කියන්න. අමාරුව තමයි කන්න බැරි එක. කන්න බැරි. So she has got loss of appetite. කොච්චර කාලයක් කන්න බැරි ගතිය තිබුණද? දවස් 5ක්. දවස් 5ක් තිස්සේ කන්න. දවස් 5මද ඊට වැඩිය තිබුණේ? නෑ මම බෙහෙත් ගත්තා. ඊට ඉස්සෙල්ලත් බෙහෙත් ගත්තද කන්න බැරි අමාරුවට? කන්න බැරි අමාරුවට බෙහෙත්. කොච්චර කාලෙක ඉඳන් බෙහෙත් ගන්නවද කන්න බැරි අමාරුවට? ඒක දවස් 5න් දවස් 5න් ගත්තේ. අම්මට කන්න බැරි වීමත් එක්කම වමනේ ගතියක්, බඩ අජීර්ණ ගතියක් එහෙම තිබුණා. මොනවත් නෑ. So I will write like this. So I will write loss of LOA, and she says 5 days. So now whenever she is loss of appetite, I want to 5 days. Now I am going to ask. So that's the main problem of the patient. Whether she had any other problems, subsidiary complaints. මේ කන්න බැරි අමාරු හැරෙන්නේ තවත් මොනවද ප්‍රශ්න තිබුණාද? නෑ මොනවාක්වත් තිබුණේ. දැන් ඇයිවා ඇතුළුනේ? ඇතුළුනේ මේ මම ගියා ප්‍රයිවට් බෙහෙත් ගන්න. ප්‍රයිවට් බෙහෙත් ගන්න ගියා. ඒක ඩොක්ටර්ට මම ඉස්සෙල්ලා ගිහින් කිව්වා මට කන්න බෑ. මේ කට සෙවලයි කියලා. කට සෙවලයි කියලා. කට දිත්තයි කියලා. ඔව්. මෙයාගේ සෙවල ගතිය නිකන් විවි. පිටට තියෙන සෙවල ගතිය. ඊට පස්සේ කිව්වා ඔයා ඉස්පිතාලේ ඇතුළු කරන්න. හරි. ඊට පස්සේ මම මොනොත් පරීක්ෂණ මොනොත් කරන්නේ නිකම් නැතු. එහෙනම් මම ලේ රිපෝට් එක කරන් බලලා තමයි ඇතුළු වෙන්නේ. ලේ රිපෝට් එක බැලුවා. ඉතින් දොස්තර මහත්තයා කිව්වා ලේ රිපෝට් එක. ලේ හොඳ නැහැ. ලේ හොඳ නැහැ කිව්වේ මොකද්ද කිව්වේ? ලේක ටිකක් උගතියක් තියෙනවා. ලේ අඩුයි කියලා. ලේ මදි කිව්වා. ලේ දෙන්න ඕනේ කිව්වා. right. එතකොට ආච්චිට දැන් දොස්තර දැන් කන්න බැරි ගතිය. So I'm going to stop there for a while. So these are true things. These are the true ways how you get exempted. This exam long case, guys. This exam long case for Erpm, final MBBS. Not only that, this particular long case that I have been doing, it comes for MD Part-2 and MRCP, all that. Right? All that begin there. So now she says loss of appetite, and also she says she went to a doctor. So loss of appetite, and also she says she went to a doctor, and that doctor has done some blood tests. And after doing blood test, they said the blood test is not good. And they are saying, lay underword. You have to learn the language, guys. It's not just very Sinhala, Tamil or English. The common expressions, the common language, the common way our people come out with various presentations. Lay adu kiyawa. මේ ලේ අඩුයි කියන්නේ මොකක්ද මේ? Anemia. ලේ අඩුයි කියන්නේ anemia එක. That means lack of hemoglobin, not that their blood volume is low, right? That means their hemoglobin is low. That's the language that they use. So that is lack of hemoglobin, anemia, right? बस पहाड़ तिबुना काटती तक गति तिबुना जैसे दोस्तर मारते हम वेन्ने गया इधर से so I'm writing like this loss of appetite for 5 days went to a GP ordered a blood count, maybe full blood count, and she was told her blood is less, so she has low hemoglobin. I mean the doctor did not say low hemoglobin. Hemoglobin की वजह पाविච්ච කරාද? එතන පාවිච්චි කරා. So the doctors have told that she doesn't have enough blood. She needs blood. So that's why she was being admitted. So it's a requested admitted for blood transfusion. she was asked to get admitted for a blood transfusion. Right? So that I have written like this. So you don't have time to write down sentences in the true exam. You write. Now sometimes in the long case there are requested admissions. So you can say this my 62 years old lady was admitted for blood transfusion. That's the presenting complaint. She said, "Lekak denna yatulune. Lekak denna thamai yatulune." So it's a requested admission for a blood transfusion. So you have to tell the exactly in patient sentences why he or she got admitted to the hospital. Okay. So loss of appetite and requested admission for a blood transfusion. Draw box, squares or rounds like this, and make a chart. එතකොට ලේ අඩුකමයි කන්න බැරි කම තමයි තිබුණේ. එතකොට ලේ අඩුයි කියලා දැන් අම්මට මොකද ඒ කියන්නේ දැන් ඇඟට පණ නැති ගතියයි කකුල් හිරි වෙන ගතියයි මොකද කකුල් හිරි වැටෙන ගතියයි ඒ පණ නැති ගතිය ඇඟ හිරි වැටෙන කකුල් හිරි වැටෙන එකයි කොච්චර කාලෙත් තිබුණාද? දවස් දෙකෙන් තුනෙන් මේක දවස් 5ක් නේද? So she also complained of fatigue and numbness for 5 days. So these are all anemic symptoms. So we can put to one column like this: loss of appetite, fatigue, and numbness of feet. So all point towards anemia. So her case is on anemia. So now very quickly you come to the presenting main complaint, which is anemia. So she has got anemia, and that's why doctor has told her to get admitted for blood transfusion. Now we have to evaluate anemia. Why did she get anemia? So when you get anemia, so what we are trying to do is we are going through the history of presenting complaint, and also we are doing the systemic review both together. හරි. දැන් මට අම්ම කියන්නේ ඔයාට මීට ඉස්සරත් මේ වගේ ලේ අඩු වෙලා තියෙනවද? නෑ. කවදාවත් ලේ අඩු වෙලා නැහැ. කවදාවත් ලේ දීලත් නැහැ. So that's very important. ලේ අඩු වෙලත් නැහැ. So I'm writing here no previous blood transfusions. Very important question. You have to ask whether this was the first blood transfusion or whether she has had any previous blood transfusion. She denies. Right. So now I am going to evaluate what is the cause of anemia. So when you take anemia, it can be losses, it can be poor supply or poor production. So losses can be GI losses or postmenopausal. Right. Now basically so no GI loss. තාරකලු පාටට basically යනකොට රතු පාට ලේ ගිහිලා තියෙනවා. ඒ ගිහිලා නැහැ. Now guys, I am teaching a great part. මේක true exam long case එකක්. හරිද? Anemia, symptomatic anemia. ඔයගොල්ලන්ට දෙනවා we get this case. So see, when you get a case of anemia, there is lack of hemoglobin, you have to put up. So this should work in your brain, in your head. That's why guys. Now theory guys, when you by heart something, still you can pass. Clinicals, you don't have to by heart that many things. All what you don't need is a big, like a good brain with common sense. But don't worry, you don't have to have common sense. I am feeding all that into your head. Right? Okay. So see the way I am teaching in that's my beautiful ward, that's my female ward, male ward patients also I brought here to do the short cases. So this is my staff and all the other people. So see. So the long case history taking is made really simple for you. Now see how I'm going to evaluate. Now that anemia, when you get anemia, that lack of hemoglobin can be due to losses. You lose blood. So anemia can be due to loss of blood. That you have to ask in the history. GI losses, GU losses, hemoptysis, things like that. Those are losses. Or worm infestation. මේ අපි කරන්නේ මේ abdomen එකේ යට තියෙන long case එකක්. මම කියලා දෙන අපේ exam format එක අපේ teaching format එක teaching skills. Then guys, the other thing is poor production. Your production in the bone marrow, like if you get bone marrow failure like aplastic anemia or myelofibrosis, then you get a loss of all 3 cell lines that I am going to teach you in this video. Listen to that very carefully. When you got chronic kidney disease, your erythropoietin is not there, so you cannot produce red cells. That's also poor production. Then you can get damage to red cells or peripheral loss by hemolysis, hemolytic anemia. So you will ask for jaundice and splenomegaly. Then also you have to ask poor supply, nutritional anemia, whether he is taking a balanced diet. See this beautifully I am covering that. So guys, I am doing the systematic review and the history of presenting complaint. Look at that. Listen to it very carefully. අරස සමාරුව එහෙම නෑනේ. හොඳයි. මේ දොස්තර මාතුරාර බටයක් කිම දාලා බලලා තියනවද උඩින් හරි යටින් හරි? නෑ. So upper GI, lower GI has not been done. So see how systematically I am analyzing those questions. So there's no GI loss. what යකඩ පෙති දීලා තියෙනවද දොස්තර මාතුරු? ලේ අඩුයි කියලා යකඩ පෙති. කොච්චර කාලෙක ඉඳලා යකඩ පෙති දීලා? යකඩ පෙති දෙන්නේ අවුරුදු 10කට ඉස්සෙල්ලා. අවුරුදු 10කට ඉස්සෙල්ලා යකඩ පෙති. So that means she had anemia for almost 10 years. She's on ferrous sulfate, යකඩ පෙති. So that means this is a chronic problem. She's coming with an acute precipitation of what your previous chronic problem. එතකොට අම්මා ඔයාගේ අර ගෑනුවෙන් පැත්තෙන් ලේ ගලලා තියෙනවද? නැග සුද්ධ වීම නැවතුණාට පස්සේ ලේ ගිහිල්ලා නැහැ මේ පැත්තේ? නෑ. So she has not got any postmenopausal bleeding. I put PMB, postmenopausal bleeding, she does not have. So then I had to ask whether there's any hemoptysis. සෙමත් එක ලේ ගිහිල්ලා නැහැ? හොඳයි. So I asked for all the losses. පණු පෙති එහෙම දුන්නද? පණුවට දෙන පෙති. මම බොනවද? ඔයා බොනව පණු පෙති නෙවෙයි. So she has taken worm treatment also. So that's also something that you need to. Even I asked that one, guys. Why worm treatment? Why worm infestation? Examiners want that with the patient because in Sri Lanka we see cases those who are heavily infested with worms, tinea infections, hookworm infestation. Like if you are heavily infected with worms, then also you can get iron loss. So you need to ask them, පණුපෙති ගත්තද? පණුවන්ට බෙහෙත් දීලා තියෙනවද? So see, every aspect is covered. Learn this process. In the case of anemia. So losses we have covered. Now the next thing is you have to ask for poor production. So if you got bone marrow failure, then you have poor production of cells. So it can be poor production of red cells, white cells and platelets, all three. So you ask for a history of to get an idea whether she got poor production. You ask for whether she got low white cells and low platelets. කවදා හරි ඔයාගේ හැමේ කොහේ හරි නිකන් අර තැල්මක් වගේ ලේ පැල්ලම් හිම ඇවිල්ලා තියෙනවද නිල් පාටට? නෑ. දතක් එම ගැලෙව්වහම අධික ලෙස ලේ ගලන ගතියක් නැහැ. So I asked for the platelets, whether she had any problems with platelet causing bleeding. No, she denies that. Then එතකොට අම්මට නිතර සෙන්ගෙඩි අමාරු, උණ අරගෙන මුත්‍රා අමාරු, then සරමගෙඩි වගේ හිම ඇදිලා තියෙනවා. So I'm asking for recurrent infections. Why? If you get neutropenia, low white cell count, you can get recurrent infections. So I covered WBC also. So I covered platelets, WBC. I asked that in this, and she denied all that. So that is the clue to see whether she has got a marrow failure, that is poor production of red cells. Then also I have to ask kidney disease. Why? If you get chronic renal disease, then also you get anemia. Why? Due to reduction of erythropoietin. අම්මට මේ මුත්‍රාණයේ අඩුවක්, කකුල් ඉදිමිච්ච ගතියක්. ඒ මොනවද තිබුණද? මුත්‍රා පෙරපෙන යන ගතිය. කවදාවත් දුස්තර මොකද වකුගඩු අමාරුවක් කියලා කියලා තියෙනවා. So she denied any CKD or any history suggestive of CKD. So I asked that part also, CKD part. So now production part is over. Then the next one is supply. දැන් කොහොමද සාමාන්‍යයෙන් ඔයා හොඳට මස් මාළු කිරි බිත්තර වගේ දේවල් කනවද? කනවා. ඒකත් හොඳට කනවා. ඒවේ අඩුවක් නැහැ. හොඳට සාමාන්‍යයෙන් මේ මස් මාළු හැම සතියකම වතාවක්ම කනවා. කනවා. So her diet is okay. So she has a balanced diet. So those things are okay. So those things I have analyzed in the case of anemia. Then now I have to see whether it's a sort of a hemolytic anemia, whether there's a peripheral destruction of red cells. So I'm going to ask for jaundice and also left-sided abdominal pain. Why? When you get hemolytic anemia, you get hemolysis causes jaundice and also you get splenomegaly. අම්මගේ ඇස් කහ වෙලා ඉම තිබුණද? ඇස් මෙහෙම තමයි තියෙන්නේ හොඳා. මේ විදිහමයි කහ. දැන් පොඩ්ඩක් ඇස්වල කහ ගතියක් තියෙනවා. ගෙදර අය කිව්වද වගේ ඇස් පොඩ්ඩක් කහපටයි කියලා? නෑ සතාටම වගේ නිකන් කහ තමයි තියෙන්නේ. කොහොමද තුවාගේ ඇස් ටිකක් කහ ගතියයි. So she says that she has got some jaundice. She said that she got jaundice. ඇස්වල කහ ගතිය පොඩ්ඩක් අම්මාර බලන්න. So you can see obviously her sclera is yellowish in color, that is jaundice. So fellow you will pull down the conjunctiva and look for fellow, but obviously now it's back to normal because we have given 3 blood transfusions to her. So she says jaundice. අම්මගේ මේ වම් පැත්තේ බඩේ නිකන් ගෙඩියක් වගේ බඩ ඉදිමිලා එහෙම තියෙනවද? එහෙම නෑ. So I asked for left sided abdominal fullness. Why is that? That is asking for splenomegaly. When you get a splenomegaly, you might get a left sided abdominal fullness. She said no to that. හොඳයි. හොඳයි. එතකොට අම්ම කිව්වා ඔයාට මීට ඉස්සෙල්ලා කවදාවත් ලේ දීලා නැහැ කියලා නේ. හොඳයි. So I have done a nice evaluation of anemia. I know this is a case of hemolytic anemia now. Why? She is having anemia, jaundice. So that favors hemolytic anemia. So now I am going to go through whether she has the systematic review, the rest of the questions in order to get the etiological diagnosis. So hemolytic anemia can be due to something like SLE or it can be hereditary hemolytic anemia. අම්මට මේ කොණ්ඩේ තරුණ කාලේ හරි මැදි වයස කාලේ කොණ්ඩේම නිතර ගියාද? නෑ. කට ඇතුලේ තුවාලාවද? නෑ. So she denied in alopecia, no oral ulcers. මේ පුංචි හන්දිවල මේ කැක්කෝ මේව තිබුණාද? නෑ. ඒව තිබුණේ නෑ නේද? වයසට තමයි දැන් මේ වයසට ගිහලා තමයි දැන් මේ හන්දි කැක්කම ආතරයිටිස් සමාරෝග එහෙම තිබුණේ නෑ. So she denied any alopecia, oral ulcers or small joint arthritis suggestive of SLE. Rash ආවේ නෑ මූණේ. So there's no history of SLE. Then I'm going to ask, so now I have finished the systematic review. බඩේ අජීර්ණ එහෙම බඩ බුරුලට යන ගතියක් මොනවත් නෑ. ඔයවත් ඇඟේ හිරි ගතියක්, ඇඟ පණ නැති ගතියක් එහෙම මොනවත් නෑ. හොඳයි. පපුවේ කැක්කුම් මොනවත් හැදිලා නෑ. අපෝගෙන් දින් ඔය වැඩ කරනකොට මහන්සි වෙන ලේ අඩුකමට තමයි එහෙම දැනෙන්නේ නේද? හරි. එතකොට නිතර කැස්ස පපුව මහන්සි මොනවද නේ? Right. So what I did was now very simple systematic review. I went through CVS, I asked for chest pain, I asked for any angina. She denied that. She said sometimes exertional angina, that's due to anemia. I asked for respiratory symptoms. I asked for cough and shortness of breath, cough and wheezing. She denied that. I asked for GI problems, diarrhea, vomiting, things like that. She denied that. Then I asked for nervous system. I asked for any weakness, numbness. So I did the full systematic review. Job done. Then after that, the past medical history. අම්මට දිය වැඩි ආව. pressure cholesterol එක මොනවද තිබුණද? හෘදයාබාධ මොනවත් හැදිලා. මේ වයසට තමයි මේ ආපු දෙටි. ඇදුම එහෙම හැදිලත් නෑ. So I wrote here no diabetes, no hypertension, no ischemic heart disease, no bronchial asthma. So previously healthy patient. මොනවත් operation එකම කරලා නෑ මේ ඉස්සෙල්ලා. So past surgical history nil. Past medical history nil and past surgical history nil. Then I am going to ask family history. පරම්පරාවේ කාටවත් ලේ දෙනවද? ඔයගේ පරම්පරාව වගේ වය ඔයගේ දෙමෝපියන්ට හරි කාට ඔයගේ දරුවන්ට කාට ලේ දෙන්න අමාරු තිබිලා තියෙනවා. මේ වගේ අමාරු තිබිලා තියෙනවද? මේ කාටවත් නැහැ. ඔයගේ පුතේකට දුවේකට කාටවත් එහෙම වියසනීප. ඔය පුතේ දෙන්න විතරයි ඉන්නේ. ඒගොල්ලන්ට මොනවද තියෙන සනීප? ඒගොල්ලන්ට තියෙන ඔය එයාගේ අදන් දැම්මා පියා මේවා ගල් කාගේද? දුවගේ ගල් අරන් දැම්ම. ඇයි එයාගේ ගල් අරන් දැම්මේ? ගල් මේ එයාගේ ලේ අඩුයි කියලා කිව්වද? නෑ ලේ අඩුම නේ තියෙන්නේ. නෑ බඩේ කැක්කුම ඇදිලා ගල් පිත්තාශය ගල් අයින් කරා. එයාට කොයි වෙලාවද ලේ අඩු වෙලා තිබුණාද? නෑ එයාට මොනක්වත්. කවදාවත් එයාගේ ඇස් කහ වෙලා තිබිලා නෑ. නෑ අර පීතාව මේක තියෙනකන් ගල් තියෙනකන් So she gives a family history that her daughter had cholecystectomy, gallstones. So gallstones sometimes in hemolytic anemia are very important. So we have a query whether her daughter had something like. I asked whether her daughter had jaundice. I asked whether her daughter had blood transfusion. She denied that. The daughter hima ඇගේ ලේ අඩු වෙන ලෙඩ මොනවත් නැහැ කියලා තමයි ඔයා දන්නේ. පුතාට තේ මොනවත් ප්‍රශ්න තිබුණේ නැහැ. පුතාට මොනවත් ප්‍රශ්න ඔයාගේ පරම්පරාවේ අනිත් කාටත් මොනවද ලෙඩ තිබිලා නැහැ. හොඳයි. So she denied any family history of hemolytic anemia or any blood transfusions, but in fact she has. So this is what happens. So truly this patient has got family history of hemolytic anemia. Her daughter also had hemolytic anemia. Son also has hemolytic anemia, but the patient doesn't know. So that's fine because whatever patient says, only you have to write down, right? Hi, අම්මට මොනවද කෑම නේද බේත ගත්තම ඇලර්ජික් ගතියක් තියෙනවා මොනවද? So allergic history බොහොම හොඳයි. මොනවද බේත් දිගු කාලීනව ගන්නවද? හැබැයි යකඩ පිටි ගන්නවයි කිව්වනේ. යකඩ පිටි ඒ කාලේ ගත්තා. ඊට පස්සේ යකඩ පිටි ගන්නේ නැහැ. යකඩ පිටි විතරයි අරන් තියෙන්නේ නේද? හොඳයි. දැන් අම්ම රස්සාව කරන්නේ නැහැ කිව්වනේ. ඒකට ඔයා තනියෙන් දින්නේ නැද්ද මොගල ගෙදර අනිත් ළමයි එක්ක දින්නේ? දුවයි පුතයි මමයි. දුවයි පුතයි ඔය. මම කුලියරේකට කියන්නේ දැන් මේ දවස්වල ඔයා සල්ලි හම්බ කරන්නේ නැහැ ෆාම් එකක වැඩ කරනවා. So she's a manual laborer, she's getting some income. අම්මන්ට සලකන්නේ දුවයි පුතයි නේද? හරි හොඳයි. එතකොට ඕගොල්ලෝගේම ගෙදරක ඉන්නේ. ඔව්. හොඳයි. So that part you have to ask in social history. I don't think it is appropriate in this particular case to ask about alcohol history or smoking or anything like that from this lady. Then what තනියෙන් ඔයාගේ වැඩ ඔක්කොම කරගන්න පුළුවන් මේ ලෙඩ නිසා ඒක කරගන්න බැරි වෙලා නැහැ. දැන් ඉස්පිරිතාලට ආවට පස්සේ වට මොනවද කරලා තියෙන්නේ? So I am going to ask intervention she had in the hospital. මේ වාට්ටුවට ඇතුළු ආවුණාට පස්සේ වට මොනවද කරේ? දැන් විශේෂ පරීක්ෂණ හරි විශේෂ ප්‍රතිකාර හරි කරා. පරීක්ෂණ ඉතින් මේ ලේ දුන්නා. කීයක් ලේ දුන්නද? දෙක. ලේ දෙකක් දුන්නා. So that I will go back to the my history of presenting complaint. She was given 2 blood transfusions. That I will note down. Right. Okay. So that part also I have covered. Okay. So now my history taking part is over. Family history also I have asked. So I have taken about now, we started at around 2:40. We have 2:53. So I have taken about 14-15 minutes because I explained so many things to you. So virtually speaking, you can do this in 10 minutes. You should learn to do it in 7 minutes. Now next classes I will reduce my teaching so that I will show you how you can take it in about 5 minutes also. So now I have to write down the summary. So in the summary I am going to write 62. So age, this is how you write a summary. Now her age is 62. So 62 years old lady. So you must write down your summary and keep, because straight away during the discussion they ask you to present summary. 62-year-old lady from Udubadava presented to us with, that's how you write. So 62 years old lady from Udubadava, wherever she is coming from, presented to us with symptomatic anemia. Needing a blood transfusion. Needing blood transfusions. Full stop. Right? So 62, that's the first starting statement, very important, that you should impress the examiner. 62 years old lady from Udubadava presented to us with symptomatic anemia, needing blood transfusion. Then you must say she also complained of jaundice. Right? That's important. And she received 2 blood transfusions uneventfully. There's no past history of blood transfusions and no family history of blood transfusions. She denies any significant GI or GU loss of blood. And her past medical history is uneventful. That's enough for the summary. So that's for the summary. Right. Now that's your first 10 minutes. That's the discussion part. So that the first 10 minutes you have to prepare summary. So examiner will ask you to present the case. Then you put your papers aside. You cannot look at the patient then you straight away look at the examiners and present. So you must keep your hands like this. My patient is, you can say someone, 62 years old lady from Udubadava, presented to us with symptomatic anemia, needing blood transfusion for the last 5 days. She also gives a history of jaundice. She denies any previous blood transfusions and she does not have a family history of blood transfusion. But she said her daughter had a cholecystectomy. She denies any significant GI or GU blood loss. She takes an average balanced diet. And she has not had any major invasive procedures in order to investigate her anemia. She denies any significant past medical history or past surgical history. And she's a manual laborer and she's having adequate family support by the family members. That's enough for the summary. So then, in your discussion, the next component is examiner will ask, what is your problem list or what are your differential diagnoses? So that's the second component. Like in the discussion part, the next question is they ask, what is your problem list or what is the differential diagnosis? And then after that they ask a question called, if you were given this patient to examine, what physical signs would you expect in this patient? And then they ask what is the investigation plan and what is the treatment plan. That's all for the discussion, right? So they ask, what is your problem list? So problem list is symptomatic anemia and jaundice. So only 2 problems. So then they ask, if you are given this patient to examine, what physical signs would you expect in him? So number 1, you will say, in my general examination. So I told you all how to present the summary, and also I taught you like how to make the problem list. And now comes that part where most of the students struggle in the exam. Those who really don't know about these real exam scenarios. That is, they ask, if you are given this patient to examine, what physical signs would you expect in him? Like that question. Like, you should be trained for this particular question in every long case. Otherwise, you can't just answer that. Now, see how I'm teaching you that. It's very important. It's a new concept that they are having in the Erpm exam since 2016. I will look for pallo, conjunctival pallo. I will look for the icterus. I will look for the degree of icterus, whether it's mild, moderate or severe. I will also see whether the patient has got any peripheral stigma of chronic hemolytic anemia, like say frontal bossing, maxillary hyperplasia. So frontal bossing, maxillary hyperplasia that you can get for things like thalassemias. Then also, in my general examination, I will look for any evidence of skin pigmentation. If the patient has got recurrent blood transfusions, you can get secondary hemosiderosis, then you can get a pigmented skin. Then also, in my general examination, I will look at the legs and see whether the patient is near the medial malleolus of the leg, and I will see whether there are any ulcers, because chronic hemolytic anemia, you can get venous ulcers. In my general examination, I will also examine for lymph nodes, because patient with various hematological malignancies like lymphoma, leukemia, you can get lymphadenopathy. So those are the important components in my general examination. In my cardiovascular system examination, I will see whether the patient has got any murmurs, because a patient with anemia, you can get systolic murmur. And also I will look at the blood pressure. And in my respiratory system examination, I will particularly look at the auscultate the lung bases and see whether the patient has got bibasal crackles, which is evidence of heart failure, because when you get severe anemia, you can get heart failure. In my abdominal examination, I will look for hepatosplenomegaly. It's very important. I will look whether the patient has got any organomegaly, particularly splenomegaly, which is compatible with hemolytic anemia. And also whether the patient got right hypochondrial tenderness, maybe due to gallbladder enlargement. Then also I will see whether the patient has got any palatable kidneys, like if the anemia is due to chronic renal failure, then you can have some kidney. I mean, if it is chronic kidney disease due to any other condition, you will get a small kidney, but polycystic kidney diseases, renal cell carcinoma, you will get a big kidney. So those are the components that I'm going to see in my physical examination of this patient, and I will definitely do a digital examination of the rectum and also vaginal examination as well, to see whether the patient has got any bleeding tendencies. Then the next component, they will ask, how do you investigate this patient? So then you must start, I will start with simple hematological investigations like a full blood count. In the full blood count, you must say what you are looking for. I will look at the hemoglobin. I will expect this patient to have a low hemoglobin. Then I will also have a look at the red cell indices, that is MCV, MCH. I will see whether the patient has got a hypochromic microcytic anemia suggestive of iron deficiency, or whether the patient got any normochromic normocytic anemia, that is anemia of chronic disease. So I will look into the red cell indices. I will also have a look at the other cell lines like white cells and platelets, because if the patient has got aplastic anemia, the white cell count can be low and the platelet count can be low. Then I will also, if the hemoglobin is low, then I will order blood picture. In the blood picture, I will see whether there are increased reticulocytes and also polychromasia, that is suggestive of hemolytic anemia. Then I will order retic count. reticulocyte count. If the hemoglobin is low and if the reticulocyte count is high, that is suggestive of hemolytic anemia. So retic count you must tell in the Excel. Then if the retic count is high, I will order Coombs test or direct antiglobulin test to see whether it's autoimmune hemolytic anemia or non-immune hemolytic anemia. So then I will also do serum ferritin to see whether the patient has got any iron deficiency. So those are my important components. And just as baseline, I will do a random blood sugar, serum creatinine because chronic kidney disease can cause anemia. Those are the components. And then if the patient, I will also do ultrasound scan of the abdomen to see whether the patient got a splenomegaly, any intra-abdominal like para-aortic lymph node enlargement, things like that. Then the other important thing is they will ask, so that's your investigation plan. And if the you will also do ESR. If the ESR is very high, and also if you have got hemolytic anemia, then that can be due to SLE or autoimmune hemolytic anemia. Then you do ANA, anti-nuclear antibody, and double-stranded DNA. Right. So that's your investigation plan. Then they will ask, how do you manage this patient? So of course, because this patient has got significant anemia, you will give blood transfusion after the blood picture, serum ferritin, and the retic count. You will give blood transfusion. So blood transfusions can cause complications. So you will watch for any transfusion-related anaphylaxis or other reactions, and you will go with blood transfusion. And then you can say, I will also get down the records of the daughter, because she said that daughter had some gallbladder extraction, removal of the gallbladder, cholecystectomy. So whether she also got something like spherocytosis, we need to ask. So if you do up to this much, you get not just a pass mark of sort of 50, you will get about 65, because that's a brilliant student. So that's all for your long case. That's how it goes. Right. So we have done the case with and so once you finish your long case, you must before you start the discussion, you must thank the patient. No?